Good morning, ladies and gentlemen. Firstly, I could explain, my name is Councillor Graham Oakes. I'm the Vice Chair of this Scrutiny Committee, but due to various reasons, I'm having to chair today's meeting. And I also apologise for those of you waiting patiently online, the fact we're on Taunton time about 7 minutes late, and we've had one or two little issues here. But hopefully now we can push on forward. So welcome very long. Particularly to the members of the public, online and in the room. The agenda pack has been made available. It's on ModGov, or you can go on the council website. There's a link there which has been sent out to all members. In line with the recommended meeting procedures, I'm requesting that all members and officers turn off all microphones and videos. But please remember to turn on microphones and videos when you speak. This helps with background noise, call quality, and anything disrupting the meeting. Including, can you turn your mobile phones onto silent, please? When I invite somebody to speak, could you speak clearly and state who you are for the benefit of anybody who's listening to the meeting so they can identify who's speaking, whether that be online or in the room. Please can also remind committee members to use the chat function solely for committee business. Otherwise, it's distracting if there are other questions or conversations. I will not be looking at a screen. I will not be. So if there's an issue on chat, I'll have to hear secondhand. Can I also warmly welcome a member of the public who's in the room and any media who join us today. It's an interesting thing that Yeovil Town Council has more members of the public at our meeting the other night and the media than we've got at this very important meeting today. Just a personal reflection. Finally, agendas are now largely viewed electronically, and can I request that members and officers refer to page numbers from the published agenda pack to assist all present in finding the appropriate information. So first thing on our agenda is apologies for absence.
Can I give my apologies? Councillor Rosemary Woods, I'm online.
Right, thank you very much.
Councillor Stewart, I'm online as well.
Sue Osborne's online, did she say?
Yes, yes.
The sound in here, it's a bit like something from the Muppets and Dr. Bob. Okay, thank you. Minutes of the previous meeting. Are you happy for me to approve the minutes of the joint meeting on the 25th of October? And the ones of Thursday, the 5th of October? Councillor Bailey.
Yeah, on page 21, as I mentioned, in Martin area, and I believe the two presenters said they'd come back to me to discuss the situation. I've not heard anything, and there doesn't appear to be any action in there. So perhaps you'd log that one.
Yes.
Thank you.
Declarations of interest. Have we any declarations in the room? No. Councillor Woods online, I think, has a declaration.
Yeah, can I declare interest on 7, 8 and 9, please?
Noted.
Thank you.
Right. Can I also say that my chairing style is rather unique, as Martin Ware will recall from other places. And I'm someone who believes in as much promptness as possible, particularly when we know that the journey home for most of us in the room is going to be entertaining. So if we can try to keep comments precise, that would be very welcome. Public question time. There are public questions from either. I'll get there one day. I apologise for that.
You hear me now? Right, okay. Right, could you, Graham, can you tell me after 1 minute loudly, then 2 minutes loudly, 30 seconds left and then 10 seconds left, please. Thank you. Okay, I'm going to address the questions, but just to summarise, I want to go into the importance of choice, distance, money, and anger, actually, but I'll tell you about that in a minute. I'm going to spend no time on the consultation because I've read, the notes, and I'll leave that. So NHS Somerset is diluting the service stroke unit at Yeovil, but it really is a false economy medically and financially. Now I read the thing and it said it's not about money. And yet somewhere else in the report, it says, well, it's not sustainable, resources can't afford it. Anyway, we know the NHS is underfunded. Regarding the concession, I said it's anything but. No, it isn't a concession. It is a step forward. Oh my goodness. Regarding the consultation. So really, the nuts of it is we need more than one hospital in Somerset, and also the Wiltshire and Dorset, some of the area. It's about choice. I and other potential stroke patients want a choice, which is not just one state-of-the-art, I admit, hospital. So regarding the consultancy, money to the consultancy firm, we can't afford it as a council. We've been threatened with a 1-1 notice, bankruptcy. We cannot afford it. Regarding Angus, it's a collaborative approach at writing my statement. And people from the Quicksilver group and trade unionists have helped me. One of them, and this is extreme and I don't agree with it, said that, is it 2 minutes, Chair? Thank you. Said, that if it happens, the dilution, and if anybody, has a stroke and dies or whatever, that would be malpractice, and grieving relatives would want to take them to court, for. Now, I don't agree with that. I know that doctors and consultants, you save lives and it's your vocation, but it's anger. And when people are grieving, they're angry. I was angry. My sister-in-law was angry with my brother, couldn't get there in time, too late. Okay, so Glastonbury I come from, Yeovil is nearer to me. Once again, so the question is, what are you going to say, Council and NHS England, to the people who have less choice at this stage regarding stroke units? Because it is a dilution of service. There's no two ways around that. 10 seconds? 10 seconds. Right, okay. So, yeah, and also drive time of ambulances, we know it's a long time. We know that sometimes it takes hours for an ambulance to get there. So we need a nearer hospital for somebody like me in Glastonbury, rather than going all the way to Taunton. Thank you, Chair.
Thank you. Thank you very much. We have Ray Tostervan online. Ray, are you there?
Yes, good morning, Graham.
It'll be the same rules for you, but
Sure.
I'm sure you know what 3 minutes is. So
yeah, that's fine. Thank you, Chair. Ray Tostervan from Yeovil's Quicksilver Community Group. We're grateful for the chance to speak on behalf of the group. Our online petition to save emergency stroke treatment services at Yeovil Hospital now has more than 7,000 signatures. Referring to agenda item 9, we welcome NHS Somerset agreeing that Yeovil's acute stroke unit should stay open. We are, however, deeply concerned the ICB still intends to close Yeovil's hyperacute stroke unit. We accept national guidance is all about developing large, well-staffed HASUs with 24/7 consultant and other specialist access with a target capacity for 600 patients a year. This model has appeal for positive patient care. Patients get a speedy response from a well-staffed, skilled and equipped hyperacute stroke unit. The ICB document being reviewed by this committee today states stroke is the single largest cause of complex disability and has a significant impact on health and social care, unpaid carers and lost productivity. Current trends predict that within 3 years, a third of Somerset's population will be 65 or over. Stroke treatment is likely to be a growth industry. Yet the NHS Somerset consultation documents present an upbeat vision. Stroke patients in Somerset, it says, will receive timely acute interventions and receive access to world-class services, regardless of where they live. It's also noted that most people with a suspected stroke are admitted to either Musgrove Park in Taunton or Yeovil District Hospital. It's acknowledged that ambulance journey times are an ongoing challenge. So in our view, it's incomprehensible to have a vision of stroke patients receiving timely acute interventions, regardless of where they live, yet propose to close down one of Somerset's 2 existing hyperacute stroke units, knowing that the result will be hundreds of patients being forced to travel further and for longer before their emergency treatment can even begin. If Yeovil HASU were to close with all emergency stroke treatments relocated to Musgrove Park, the expected capacity at MPH will be around 815 patients. Add to this 215 patients from Somerset who currently rely on Yeovil HASU, who would go to Dorchester County Hospital instead. That's 1,070 patients, just short of the 1,200 patient target for 2 fully functioning HASUs here in Somerset. And with rising demand for emergency stroke treatment as our population gets older, the need for emergency stroke treatment will only increase. So finally, we ask this committee to urge NHS Somerset to review and reject the proposal to close Yeovil's hyperacute stroke units. Thank you.
Thank you, Ray. I was as tolerant with you as I was with Eve for a few extra seconds. Thank you very much. I'm unaware of any other members of the public who wish to speak. I can't see anybody online. If there is anybody out there who's desperate. No, you've missed your chance. Right. Next item on the agenda is the work programme. And you members of a copy of this has been circulated. On the second page of the document, you'll note that we have a number of items and they will be coming to the committee going forward. We can add additional items, though we're struggling, I think, at the moment to get through the ones we have. Do members have anything else they wish to add to our list? Right. Oh, sorry, John.
Chair, John Bailey, Martok. Is this in addition to the items to be added to the agenda and the agenda, both items, or just in addition to all that? Sorry, I'm unclear about where the additions are.
Right. It's whether members wish to add any other items to our forward plan. We have before us what we're dealing with now and what we're going to be dealing with over the next few months, and it's whether there's anything else we wish to add to that.
So we're looking at the whole of both lists, basically. Thank you.
Yes, it's whether we want to add anything on the bottom of that.
Thank you.
Councillor Pearlstone.
Given what we'll be discussing today, could we possibly revisit this towards the end of the meeting? Because there may be things that come up that spark additions that we may want to look at for next year.
I think that's a reasonable request. Jenny will remind me because I will forget. Councillor Hilary Bruce.
Thank you. I can't see on the list anymore the review of the workforce, which I thought was something that we were going to look at. Seems to have disappeared off the list completely.
It's reappeared on this list now.
Thank you.
Thanks to you. Any other items? Right, thank you. Moving on to the crime and disorder overview report, which is item 6 on your agenda, pages 25 to 44. We've got Claire Stewart here, who I hope is going to be presenting this. Matthew Hibbett's gonna to start us off. Matthew.
Thank you very much. Thanks, Chair. Yes, I'm Matthew Hibbett. I'm a consultant in public health in the public health team, and the reason for me just saying a couple of words of introduction is that members may be aware, but the community safety team in Somerset Council is hosted in public health and has been for a number of years. I'm in the privileged position of managing Lucy McCready, who is our community safety manager, and she would normally have been here to deliver this presentation. I mean, I've worked in Somerset Council for, well, County Council as was for about 13 years, Lucy longer than that, and I think this is the first one she's ever missed. Sincere apologies from her, she is unwell. However, we have Claire, who is more than able to present the information to you today, and obviously we have colleagues from police, and I think we also have Councillor Shearer, who is the chair of the Community Safety Partnership, so I'm sure we'll be able to give you all the information you need. Nothing else from me, but obviously I'm here should any questions come my way.
Thank you very much.
Thank you. So as Matthew mentioned, my name is Claire Stewart. I work in the community safety team at Public Health, and I'm just going to give you an introduction and overview to community safety in Somerset. So the slides I'm going to show will cover the prevalence and statutory duties, Somerset Council's community safety function, the Safer Somerset Partnership and their key functions, and some of our key achievements and challenges looking towards the future. So first of all, what is community safety? Community safety is activity designed to prevent and reduce crime, disorder and antisocial behaviour, and to reassure communities so that they feel safer. So on the diagram, we've got some examples so you can see how diverse the work can be. It stems from community engagement, youth crime, environmental crimes, terrorism, exploitation, and substance misuse disruption. We take a public health approach in Somerset, and there's a quote there from Gary Slutkin, who's one of the first.
So can I just check, for those of you who are not in the room, can you see this really nice presentation that we're seeing as some?
Yes, we can.
You can see it.
I can certainly see it, yes.
I can't see it. Where is it? It's not appearing as part of my screen. That's Councillor Woods.
The presentation is in the pack, so I'm afraid we're going to have to go sideways on that if you want to view it. We're not going to be able to solve it with individual members at this moment, I'm afraid. So please, Claire, can you continue?
Yeah, I'll look to reshare in case that helps with some connection. So we take a public health approach here in Somerset. Violence is treated like a disease. There's a quote there from Gary Slutkin, who's one of the American researchers who first adopted that approach in terms of violence prevention. So we know that violence is preventable. In terms of its prevalence, the chart here is taken off police.co.uk. It shows recorded crimes per 1,000 of the population. You can see the red line here represents Somerset. We are below average in Avon and Somerset in terms of our recorded crime. However, on this website, the Home Office select what they call similar average groups. So areas with similar demographic makeups to Somerset, and you can see that we're slightly above some of our authorities nationally who may have, you know, a similar makeup to this county. We've got a focus here on a couple of specific crime areas. So one is public order offences. This is a slightly different styled chart, but if you look at the blue bar, you can see that Somerset is above the upper boundary of what they're looking at in terms of average on the same sort of scale of the most similar local areas to Somerset. It's also slightly above that upper bar on the second chart for violence and sexual offences. We have a number of statutory duties in regards to community safety that are listed here. There are 8 of them. While some of them span across all areas of community safety, there is specific legislation in regards to domestic abuse, domestic violence, antisocial behaviour, counter-terrorism and domestic abuse. So as a partnership, this is the legislation that we have to adhere to in terms of improving community safety within Somerset. The community safety, I think someone's just joined and they're not on mute. Thank you. The community safety function at Somerset Council, there's a strategic function. So that's when that legislation is translated into local policy. We ensure that the council discharges statutory responsibilities regarding those legislations on the previous slide. We work around the strategy development and commissioning and service design and allocate budgets set against strategic priorities. We also manage partnerships and systems change for continued improvement. At tactical level, the council will carry out needs assessments so that we understand what the need is across the county, and that's done through collecting intelligence and data. We work together with partners to problem solve and monitor contracts and make sure there's quality assurance process, such as case reviews in the work that's carried out. At an operational level, we provide community engagement, which is a really important part of our work, particularly as fear of crime is just as important in some areas as what experiences the community have. We carry out public facing community work around prevention, case management, and there is enforcement role in terms of environmental crime and antisocial behaviour. And that filters off into our neighbourhood work in terms of tenancy support. This is the structure chart of the Safer Somerset Partnership. You can see the S in the middle, the green S. It reaches out towards the other boards and partnership that maybe have similar responsibilities or where we can utilise and collaborate more effectively. And then underneath that partnership, because of the specific legislations that were on the previous slide, we have subgroups to help look in more detail and develop that work. The subgroups are the Prevent Board that deal with counter-terrorism, Hate and Community, Cohesion Partnership, the Domestic Abuse Board, and the fourth one is relatively new, and that's the Violence Reduction Partnership that's just forming this year. We have a community safety plan that has got one more year to go, so until 2025. The current plan has priorities to protect people from the harm of domestic and sexual abuse. A couple of examples of project work under that priority are a She project, which is supporting women who may be involved in the criminal justice system, offering them therapeutic space. We've also tried to improve domestic abuse data sharing through the facilitation of administration and notifications with health. The second area of priority is to improve Somerset's response to serious violent crime. We have communications work to help reach out, improve awareness. We've been purchasing bespoke packages to support schools and communities in terms of response. And we've got a hospital navigator programme at A&Es to help support people attending, particularly at weekends, and we'll cover that a bit in a couple of slides. Third priority is around neighbourhood crime and antisocial behaviour, and a couple of examples of projects within that remit are Jumpstart, which is a sports mentoring project for young people at risk of ASB. In Somerset, that's provided by Somerset Activities and Sports Partnership. And also a buddy tag system, so personal monitoring to help with safeguarding for children at risk of exploitation. This is just a closer look at some of our domestic abuse work in the last year. So there's been new domestic abuse legislation under our statutory duties. This has resulted in the redesign of the domestic abuse service from April 2023. We've increased the portfolio of safe accommodation, improved the working with children's services, and we're trialling a new style of counselling for victims of domestic abuse. The Domestic Abuse Board has had some redevelopment, and there's been investment in digital solutions, as well as campaigns. This is just a snapshot of one of our latest campaigns. This came out on the 25th of November, Beyond the Bruises. This is talking about the new legislation that requires us to understand non-physical domestic abuse, sometimes referred to as coercive control, to raise the profile. We have got examples on that YouTube link of some of the campaign materials, short 30-second films. I will say to people, the content for some people may be sensitive, so that does come with a trigger warning. But for those who feel able, we do recommend to have a look at those in your own time so you can understand some of the issues that we're expected to understand moving forward. As we mentioned, we've got a focus now on serious violence. Just to give some context around that, serious violence has been rising in the UK since 2014. By 2018, the Home Office had a national strategy recommending that public health approaches should support the reduction of violence. And by 2019, Somerset was formed as part of Avon and Somerset Violence Reduction Partnership, formerly known as Violence Reduction Unit, to improve multi-agency work around the reduction of serious violence. Our headline data is there. I just want to highlight that at the bottom, because Somerset remains a safe place to live. We have done a needs assessment on that. However, a third of recorded serious violent crimes in Avon and Somerset occur in Somerset. Police data suggests we've had an increase in the reporting of knife crime, youth violence, domestic abuse and sexual offences. Some of the activity for this partnership over the last year includes the commissioning of interventions. The total grant was just over £530,000 for the year. Approximately 70% of that was spent on interventions. We were able to reach almost 1,400 young people considered at risk and provide 800 training spaces for professionals, and just over 7.5 people were reached through face-to-face engagement in schools, parks and town centres. This is a case study of one of the projects I mentioned earlier, where we've got navigators, support workers in A&E at peak times. That service is provided by Turning Point, who are part of Somerset Drug and Alcohol Service. They go in late at weekends into the early hours. And to give some context, this is one of the case studies that they've presented to us. They had a young male, age 15, come in with an injury to his hand. He reported that on Saturday morning at 3 a.m. he was out, a car pulled up, two men got out, beat him up, stamped on his hand, pulling out one of his nails. This was associated with county lines. So because we had the navigators there, the support workers there in A&E, they were able to connect with him and get wraparound support and quite a quick strategy around his safeguarding in place. So the challenges for the community safety function that we operate are that it's reliant on short-term or annual grant funding. So it's really hard to plan for those long-term solutions. We're trying to advocate for prevention, but systems are quite reactive that we have to work in. Since LGR, some of the functions that were highlighted earlier are spread across different directorates within the local authority. So it's how we overcome that challenge. Resources are limited, but the agenda is constantly changing and growing. And there is a high number of needs assessments and strategies throughout the year that we have to produce, but we have minimal resources to respond to those. The final point is around domestic homicide reviews, which is one of our statutory responsibilities. They are expensive and the numbers of those are increasing. So our current priorities are to review the functions across the council, and the meeting arrangements for the serious violence duty and how we respond to youth violence. We've got a new collaboration with North Somerset to provide analytical work, additional analytical capacity around the data we need to inform where we need to focus our attention, and to complete Somerset reducing reoffending strategy. And that's it. It's time for questions.
Members. Councillor Bailey.
Thank you, Chair. John Bailey. Just a question on the practicalities, really, and thank you for your presentation, Clive and Matthew. It's really, I'm involved with in Martock with directly and indirectly with a number of youth groups, which was set up following the pulling back of the county from any youth support. And it's really how we would interact with the agency, your agency, or the group of agencies. And we do get a lot of support from the local PCSOs, but I'm fully aware that anything that is often a real multi-agency approach, and all of the people, well, we have paid youth workers, obviously, but all of the people involved running these things are volunteers. So less or greater experience, but they do need a lot of support. So if there are issues occurring, I'm trying to sort of understand on a ground level how you would support the youth groups that I'm involved with, and where we would go if we had an issue to sort of discuss with you. Thank you, Claire.
Thank you, and that's a really good question, and we get similar inquiries around youth support, obviously across the county. We are a partnership, and on the presentation I sort of said that one of the priorities is to look at how we work around youth violence. In terms of youth groups where they identify people with need, we have an early intervention team within the police sat behind me, and there's a dedicated role within each former district area of Somerset to help liaise with where we think a young person is at risk of violence. A separate sort of stream of work, if you like, is how we support young people who need that very early diversionary support. So to engage with clubs, it sounds like in Martock you've got quite a good setup, which is great. We have information packs that we can send out to youth clubs with the various support information that young people may need. So I can follow that up through democratic services and get that information sent to you, because there's a lot of different scenarios where young people might need support. It might not be around risk of violence or antisocial behaviour, but there are a number of other voluntary sector agencies that we connect with that could provide that. So we can forward that.
Please do.
I just wondered whether you'd considered having, because it is such a complex situation of organisations, and I think there were 13 in one room I was involved with, have you considered having some sort of relationship management approach to the contact at the ground level? So, I mean, I'm going back quite a long time, but the Kirsty Brown would have been involved, and Jeff, I'm going back a long while. So you knew who the people to be engaged with at the time. I'm not sure whether I would know them now, because I don't know where they exist within Somerset Council, which was the county. So it's that sort of first point of call, and someone, because there's a relationship built up, may also have a knowledge of the geographical area that they're covering. I just wondered whether you'd sort of consider thinking about with the complexities that we're involved with.
Yeah, I think it's a good point. Are you referring to people who historically have provided youth work?
Yeah. Youth work support, yeah.
Thank you. So, yeah, obviously you mentioned that the youth service changed, resources changed. But at the moment, there is some regional mapping occurring of across the whole of Avon and Somerset, coordinated by the Police and Crime Commissioner's Office to look at where provision is and where the gaps are. So that's one piece of work that is happening, and they're going to correlate that work with geographical areas where there are concerns about antisocial behaviour and youth violence. So that bit of work's ongoing. Whether that can form strategy or I don't know. In terms of connecting youth services and go to people at the council, I will take that back and go to democratic services and see if that's a conversation that's already happening. I think Matthew Hibbert might have some additional information on that.
Matthew?
Thank you. Yeah, I was just going to respond to that point and say, I think you're absolutely right. We've got an opportunity with the development of the new structures in our new organisation to re-establish some of those links. You mentioned Jeff Brown, who's obviously still with the authority. I think that link across to the voluntary sector, we have to explore how we make sure that we're joined to the part of our new organisation that is providing that sort of management link, as you say, across to voluntary sector organisations. So it's a good one for us to take away and think about, because I think the community safety function and Claire's role in particular around violence reduction should link into that. So it's making sure that we don't duplicate what is developing in the new structure, and I think the opportunities are there. So thanks for raising that. I think we'll take that on.
Thank you. Councillor Sally next.
Thank you, Chair. I'm alarmed to read that police data suggests Somerset has an increase in the reporting of knife crime, youth violence, domestic abuse, sexual offences, and a third of recorded serious crimes are in Somerset, which is alarming. Two questions on that. Is the data, presumably the data is broken down into areas? Is there concentrated areas, and are resources sort of dedicated to those concentrated areas? And then the second question is, you've alluded to short-term funding making it difficult for strategies, and my understanding is that police have £3 million worth of cuts over the next couple of years. So I kind of feel for the police. They've got a growing problem, but their resources are being diminished. So are we looking forward to potentially worse figures, which is really very troubling? Thanks.
Thank you. I think just to answer the first section of that, yes, we do have data that breaks down where the need is greater. And just to reinforce, although the stats show there's increases in those crimes, so for instance, knife crime is still low in Somerset. So the increase, the amounts we're talking about is very small. Domestic abuse accounts for a third of all serious violence in Somerset, so that's a slightly bigger chunk. So we have needs assessment data, and I can send the link out to our full needs assessment information through democratic services, so you can read that in your own time. I think in terms of the query around police resourcing, we've got colleagues behind me representing the police who can answer that.
That's it. It's done. Thank you. Can you hear me now? That's absolutely pertinent to the policing position we're in, and there are real challenges. But that said, there are definitely some efficiencies in how we work as a team to make sure that the resources are in the right place. What I will say about sexual violence and domestic abuse, I've just come from a CID role straight into this role in recent weeks, so that was my bread and butter. Yes, the Somerset area does have a higher prevalence of it, and it has slightly increased dramatically since COVID and now levelling out. But what the force has got in terms of response to that is, and has been, groundbreaking. We are the national lead in Operation Bluestone, which deals with offences largely against women in the rape, serious sexual offences arena, but also it's now shaping how we're able to deal with domestic abuse. Now, that doesn't take away from the fact that we want to, of course, stop more victims, but the service that we are now able to provide, and Somerset's really benefiting from that national groundbreaking programme, is and can be bespoke to the victim care wherever. And the benefit of me joining into Somerset with that knowledge is that I lead that with a real passion and really clear that I want to make a difference with how the partnership works and targets the focus in those areas. So, you know, to give you a feel, I did break down a little bit of data, but we have about 4,000 crimes of assault with injury in Somerset in the last year. It's about 10% of sexual violence assaults. So the numbers are stark. The sexual violence prevalence and domestic abuse violence prevalence is worrying, but we are a constabulary that has got a response, even with limited resources, to do that really, really well.
Very quickly come back, please.
Yes.
Thank you for that. It's really good to hear the positives and the work and the innovations. And I have no doubt you're doing that, pushing that forward. Just back to Claire's comment. Just for those who can't see the bar charts, it's just the public orders offences and violence and sexual offences compared to other areas. We are the highest on public order offences, and we're third for the highest for violence and sexual offences. So that's what I'm looking at. Oh, thank you for contextualising it and reassuring us and residents. But it just, with what I understand of funding cuts for the police, I do feel that the challenges are pretty stark over the next few years. Thank you.
Thank you. And just to come back on the comments about the data that's shown. So although we're compared to we're higher, just to put it into context, we're compared to our, what they call similar neighbours. Those similar neighbours are set by the Home Office, and I can also forward a link through Democratic Services of how they select who your neighbours are on that data sheet. It's different with public health. They use a different set, but this is of police.co.uk. They will have picked local authority areas where the makeup is similar, so the overall crime rates are likely to be lower. So just to put that in context, and although we're in the upper band, it is a good point that potentially there's practice we could learn from other areas, and it might not be around policing. It could be there's something different environmentally about our areas and other areas. So although it's a good guide, you know, to really dig deep, we need to understand that a bit more.
Councillor Whale caught my eye next, and then it'll be Councillor Bruce.
Thank you, Chairman. Looking at page 35, which is the partnership structure, got me thinking. I'll be sitting here tomorrow on the crime panel, Commission's crime panel, and we'll probably be talking about exactly the same thing. And what made me think was the many committees of the, I think they're subcommittees, are they not, of the Safer Somerset Partnership. And there seems to be, to me, an awful lot of repetition of similar material will be going into all those groups. And I know the police have to attend them as well. It's all time taking up. And then I got to thinking, some are marked statutory and some aren't. And now we all know what's coming down on top with the crisis of finance. And I'm wondering how many of these will be able to function when they're not statutory, the main thing. And also, is there not a position where some of these, frankly, should be merged? There is definitely a crossover among Somerset violent reduction and domestic abuse are the same thing, for heaven's sake. So it strikes me there should be some sort of filtering down of this system to A, because it will cost less, and B, it will be better for the information coming out of it and the workforce. Thank you.
Thank you, Councillor Well. I would suggest that over the next few months, all members of Somerset Council will be asked to look at what we do and to look to make it more efficient, frankly cheaper. Sorry, please want to come back.
Yeah, and I will pass to my colleague as well, because I think we probably would have a view on this, but it's really, really important. I didn't make it clearly in the last point. The efficiency of understanding where we need to be as a group of partners, where we need to invest our energy, is all based on efficient front door meetings, understanding what the priority areas are, where the demand is, where the risk, who are the families that need support. Really good tactical partnership working on a regular basis with maximum attendees, because only in that do we get the efficiency of understanding where are we putting, quite frankly, the limited resources, and where are we stopping the demand from growing and the risk from growing. So absolutely our focus is working with partners to understand what is the resource, and then how are we going to maximize it, on very regular basis in very localized formats to understand the problems cluster by cluster. But I don't know, Andy, if you wanted to put
Yeah, I think Councillor Whale makes a really good point. You could have a hate crime, which is a domestic violence incident, which is serious in its nature. So there is always crossover, and actually streamlining that efficiency is really important to us, especially as we face the challenges with limited resources. To reassure you though, the tier under that, how we actually operate right across Somerset now, does just that. So we have what is called a priorities meeting, and that at a sort of tactical level has actually merged the various different groups that sort of went before. So there was a hate crime group, there was an antisocial behaviour group, there was a nighttime economy group. That's all been merged into one. And that's a multi-agency framework, which actually has streamlined that and actually made it a lot more efficient. And the frequency, once every 2 weeks, means that we're just putting the limited resources exactly where we need them at any one time. But that governance structure is something worthy to look at.
Thank you, Councillor Bruce, and then Councillor Pearlstone.
Thank you, Chair. I've got one kind of specific question which could come out from the report, and then I've got some comments about how we might look at this in the future. Do you want me to put those to one side until later, the comments about how we look at this? Just all together, okay. So, okay. Thank you very much for the presentation. It's a really good overview of what you're doing at the moment, really useful. You mentioned in the report about an upgrade to CCTV in a particular area. So a while back, last year, I think it was, it came out that there was going to be a reduction in spending on CCTV systems. And we've also got problems in terms of the various districts having different systems and some of them not working properly. And so it's a very disjointed system in terms of CCTV across the area. And I just wondered, obviously we've got certain constraints at the moment, extra spending is not going to be possible. I think the intention was to do a review of all those systems and then have perhaps a single system, upgrade it all in one go, but that's probably not going to happen now. Is a review still happening of the CCTV systems, whether the problem areas, the ones that are really specifically a problem, do those need upgrading, and can we prioritise those?
Mics. Oh, there we go. Yeah, thank you. So one of the items I mentioned on the slide was that since LGR, obviously one of the priorities we're looking towards at the council is to understand how the community safety functions work across different departments. So CCTV is a good example. So a lot of this work, the strategic work, happens in public health, but CCTV is an operational function. So in terms of where that's at with the review, unless my colleague Andy has been involved from the police side, I'd need to forward that through democratic services, because the council officer for that directorate area would have more information.
I think Matthew wanted to come in. No, he doesn't.
No, sorry, Chair. I was just agreeing with what Claire said. I'm afraid that is exactly the picture. So, because of the way that the operational functions are in a different part of Somerset Council, we don't have the answer to that question, but we can certainly follow it up and get a response to you.
Yes, she does, but I'm calling committee members first. I'm not ignoring the new the councillor.
Chair.
I would just point out, when we look at CCTV, can remember that some of the funding does come from parishes. And if you can ask for more money from us, we'd like to know. Councillor Bruce, would you like to continue?
Thank you very much, Chair. Yeah, I understand that we're looking at this as public health, so that's why it's come to us. I think in the future, and I don't know at what point we would be looking to review this, whether it's 6 months down the line, I think possibly we need to look at it as a joint committee with the community scrutiny. I know that other committee members were invited today, but I think if we do a specific joint committee, it encourages more members to attend and get involved in that. So I think I would be interested in seeing, I mean, we were asked, you know, how we want to see it run and what we want to see in there. I'd like to see some more specific data broken down, you know, the crime data broken down by area and by type. I'd like to see highlighted what you believe are the areas of concern that we need to be looking at, what is particularly under-resourced. I'd like to see a bit more information about the budget that you're working with and how that budget has been spent over the last period, where that effort has been put into, and obviously a bit more information about the progress in terms of the structure of the community safety team, and where that work is going on that. I think that's it for me. Thank you.
Yeah, we can definitely do that, especially in terms of the data. We've got some work in progress already to try and get some more detailed data around different crime types and hotspots, especially in relation to antisocial behaviour, which would tie in with, you know, we need to tie CCTV locations in with that to understand where they're matched or not matched as part of the review. So yeah, absolutely.
If it is going to be a joint community, then we will invite the police again and hope they could be here, because we may have some more interesting questions when we get into detail. Councillor Pearlstone.
Thank you very much. I appreciate that it is just an overview of generalisations, and I agree with Councillor Bruce that breakdowns of certain types of crime and things like that would be very helpful. I'm interested in the words recorded crimes per 1,000 population. What does recorded crimes denote specifically, please?
I'll let my police colleagues, that's recorded with the police referring to, so I'll let my police colleagues explain if I'm recording.
Simply put, it's, you know, matters will be reported to us in volume. Something might be reported as one thing, but there might be 7 things that we find there that are all separate crimes. Domestic abuses or antisocial behaviour, both really good examples. So reports police get and then what is recorded out of it are 2 different things. And sometimes things that are reported as a crime aren't actually a crime. So it's that anomaly of what we record through Home Office counting rules that actually register as an official crime. So not as an occurrence, not as a report, not as antisocial behaviour, which doesn't necessarily report as a crime. It's what is actually a crime as defined by the Home Office, and in the volumes that are associated with perhaps 1 call, multiple crimes, or multiple reports and 1 crime, if that sort of helps.
Would it be at all possible then to see alongside this crimes that were then prosecuted comparatively to recorded, please? As we all know, that sexual crimes especially have an incredibly low, possibly even charge rate, and even make it to court. So seeing those variations between what is recorded and then what is prosecuted would be quite an interesting thing to see. Thank you.
Absolutely, and we obviously, as you'd expect, track that data both in areas and in regions, but also in crime type. And yes, the recorded crime and the outcomes for sexual offences has been historically really low and very well quoted as under 1% nationally. It's not something I'm celebrating, but in this area we detect, we send to court over 10%.
You were added by some, okay.
Over 10% of that's reported. So we've gone in Somerset in the last 3 years from under 2% to around about 10%. So there's still 90% of victims that don't get an outcome charged by the Crown Prosecution Service. So that's the point I would really want to make. So I'm not celebrating 10%, but the trajectory is steep and it's rapid. So yeah, I can understand absolutely why you want to see that, and we can commit to that when we have the next group.
I'd just like to say, hearing those figures, I agree about celebrating the numbers is not the way you want to look at it, but the improvement and the knowledge that you know, prosecutions are happening at a greater rate than in other areas is to be yeah, a difficult word to say well done, but well done. Thank you.
We've been joined by Rick Wally. It's our protocol here that we have cameras off until you're actually speaking, if you are going to be speaking. So we'll keep you on mute, and that helps with bandwidth and other things. We're going back to more questions. I did note to you, Councillor Shearer, but I'm dealing with committee members first, so please continue to be patient. Martin Whale.
Thanks for letting me back, Chairman. Page 40 mentions the grants, 531 nearly. Are there other grants available for this work as well? Both, I know there are. I think there are to the police and to ourselves. And the second question is, that shows for this year's grant. Is it going to be continuing, or don't we know yet? Page 40, it mentions 530,000 VRU grant. Oh, it's probably because I got.
Sorry. That's all right, thank you. So at the moment, so that is external funding that comes down through the Home Office. There are more, so we haven't shown the overall grants that come in there. There are other grants related to those other subgroups and statutory duties that come down. So there is more information we can share on what all those external grants look like. Again, we can share that through Democratic Services after the meeting. In terms of that grant, that's specific around the violence reduction work that the Home Office have been promoting ahead of the statutory duty to reduce serious violence. It has been set for 3 years, which is due to end 2025, and we haven't got information about what will happen after that period. There is a smaller amount, much smaller amount that is coming down as burden funding because the legislation has come in, but we haven't quite got guidance. That's administered through the Office of Police and Crime Commissioner, so we don't have guidance on what that looks like moving forward either, but it's a good question. So external grant funding around crime reduction and violence reduction is something we can share more information on.
I would also add to Councillor Wells' point, and I'm not going to talk about the funding because I think that'll be a later meeting, but in terms of the objectives that are set from the Home Office as well, and this presents the challenges but the opportunities as well. Under the Violence Reduction Partnership, for example, we are set a mandate that we must deliver something called clear, hold, build, and we've done the intelligence checking, which actually means we've got to clear the crime, the violence, the organised crime, county lines issues in a very bespoke area. Hold the line. So once we've cleared it out, all the criminality, rebuild the community confidence, and then the build part of that is for local authorities to utilise funds that they already have to prevent the teams coming back in to commit those crimes again, and then have the whole downward scale. None of that comes with any funding. So whilst we're really lucky in Somerset that has identified that we're going to benefit from that objective running very well in the Taunton areas and potentially the Highbridge areas, no funding comes with that. So the opportunity for us to collaborate is strong because we've got government mandate, but there's lots of other pressures that don't come with funding that we must deliver.
Mr. Bruce.
Thank you. One thing I did forget to mention earlier is for future reports, it'd be useful to have some performance indicators, something that we can monitor on a consistent basis going forward. So I'm assuming that's something you're already kind of have an idea of what you're using. So perhaps getting a list or some information about what you currently have, and then members could feed in if we feel that there's anything missing of that list that we could then include in future reports, please. Thank you.
That's no problem at all. We have a number of statutory indicators, and then we have our own local ones as well. So yeah, that can be provided.
I think that's all the members in the room. Councillor Shearer.
Hi, thank you, Chair, and thank you, members and officers. I forgive me for putting my hand up so early. I just wanted to say something at the end, so more than patient to wait. I just wanted to say, first of all, to thank the officers who have been presenting, and also the police for coming along, as well as our very important partners. I've been on the Safer Sunset panel now for coming up for 5 years, 4.5, 5 years, and I was amazed at how much statutory work was covered by so few people. But it's that extra kind of bit you get by working in a partnership. So I'm really pleased to see the partnerships growing all the time, and we are making the most of very tight resources, I think, in every agency that's involved with Safer Somerset Partnership. So I'm really proud of the work that gets done through the group. I think it's really good. But what I'm most pleased about, though, that it's come here today, and that everyone around the table has been really engaged with it and wants to ensure that we do our job better, and they want to keep an eye on what we're doing and come up with good ideas for how we can do that, because that's really important. So thanks to all those people who have been, challenging nicely, because sometimes I think some of our officers have probably been feeling they've been working in the vacuum doing really good stuff, every part of which is statutory. I don't think there's anything that we're doing through Safer Somerset Partnership that is not statutory. That's the point really of our being. So it's really good to get the recognition as well that we're doing a good job with it. But I just want to say thank you so much for that. And yeah, thanks for listening and thanks for contributing.
Thank you for thanking. I think all the members have covered this now. The recommendation was that we consider the format and segment of this, and I think we've actually done that. I know Jenny's written down lots of things to take forward for a future meeting in a few months' time. I'm sure you do excellent work. If you're in a vacuum, it could be difficult, but we are aware of you, and we'll be even more aware of you when the next time you come to possibly a joint committee. Members happy that we move on? Thank you very much. Please feel free to leave. You've helped us with our investigation. Thank you. Next item on our agenda.
On the wrong page.
We're about to be there.
If you can get it up quicker than me.
It's time to move on to the adult social care budget monitoring. It's month 5, and I think we're always 6. It's 6 there. It says 5 on my agenda. And time moves on. That's how long the meeting's already gone. That we're in the following month. And Penny Gower is going to introduce the report.
Thank you very much. Yep, as you just mentioned, we'll be presenting budget monitoring month 6. But before we go into month 6, we thought it would be helpful to just show a breakdown of how the budget's made up at the moment. So as you can see, 93% of the adult social care budget is actually spent on statutory care and support. 6% is spent on staffing, with 1% being spent on commissioning. And I know before you've had lots of questions around what is statutory, what isn't statutory. So I don't know, Mel, if you want to add any information here.
No, I think let's keep going, and then if people ask questions, we can do it at that point.
Okay, thank you. So if we move on, the total overspend for adult social care for month 6 is 24.2 million. This is offset though by one-off mitigations and one-off funding, which we will discuss on the next slide, to reduce the overspend down to 14.9 million. As you will see, this hasn't moved since month 5. We've kept this stable. As part of the in-year mitigations, we've received some one-off monies from NHS, We've also, the ICB are currently funding the home care blocks. We've had funding in one-off from the market sustainability of 3.7 million. We've achieved savings against the voids. We've also got savings in against the reviewing mental health high cost placements, around reviewing community continuing healthcare, so CHC, reviewing high cost placements, reviewing interim placements and one-to-one. So there's lots of reviews to be taken place and are taking place to see costs reduce across the year. Then moving forward, so in terms of the MTFP, medium-term financial plan, we've just brought this again so that we can track this and present with you. So we have the My Life, My Future project. So as you know, 5 million was built in to be saved this year. We're on track to achieve 0.2 million due to the original rollout. Just we're not able to achieve those savings this year, but they will be achieved next year. The use of DFG to fund equipment, we're on track with that. And the community focus redesign we have achieved. Sorry, really quick overview, but are there any questions or comments?
Members, Martin Whale and then Councillor Sutton.
Yes, can you expand a bit from my information, really, or our information, on the medium-term financial plan, which is, I don't know what page it is, what slide it is, but anyway. Oh, 57. It's the unachievable Newton Europe savings. What's the reason for that unachievability?
Do you want me to answer that one for you? Probably makes sense. So we've got lovely feedback, haven't we? We've got a presentation later on around Newton. What we always knew, so this isn't unusual, what we always said when we took the Newton contract on, which is with us, and so this is something we do together, and we got that extra capacity in, we knew we would not make full year savings in this year. We've only started that contract 3 months ago or 4 months ago now. So we knew in year, and we always said that. So when we took the contract on, we knew we would make £10 million saving over a 2-year period. What we did at that point was put 5 in one and 5 in the next very early on last February. So what we accept is we'll have to take some money out of reserves this year to pay for that or overspend, and then put that money back in next year. So we will make it in 10 years. We'll describe the programme to you a little later in this agenda, in the next agenda item. But that was expected when we signed the contract off, and we talked that through both in the scrutiny conversation earlier on and also in our exec meetings.
I appreciate that, and I thank you for the explanation. I wasn't on this committee. I'm only subbing as my colleague here. Can you, what is Newton Europe? It's some sort of system to save money. Can you explain that?
So we've got an agenda item. The next agenda item is to bring to you, and we've got a presentation on the My Life, My Future. So My Life, My Future is the Adult Social Care Transformation Programme. And what we've done is worked in conjunction with a company called Newton Europe, who are the experts in the field out there, to give us that additional support so that we have that to be able to make the transformation. But we will describe that, if that's okay with yourself, in the next agenda item. Is that all right if we do it in that way, rather than having that conversation now and then doing that as the next agenda item?
Yes, please.
Thank you, Chair. Sorry.
Councillor Claire Sully.
I'd like to ask a question about the efficiency savings as well, but listening to that last response, do tell me if you don't think it's the right time to ask this question. But it's around, I attended an assessment meeting around a support plan with a family yesterday, and the 2 social workers were there. They were great, fantastic, and the situation was difficult because the package had been cut, respite package area had been cut. That isn't my question in this specific case. But what I noticed is where the discussion was around the semantics of the reasons not to cut the respite package didn't meet the outcomes, but these outcomes, it seemed a lot to do with the language that was being used. This is my point around efficiency savings. So what I learned yesterday, that this query, in order to look at this particular assessment and support package for this family, there would have to be, as well as the 2 social workers sitting there, there would have to be a peer forum which involved 3 people. Then there would be another strategic manager involved forum, which is 6 people, for this one query to make sure that why the family was saying we want this respite package, we believe we should have it cut, just seemed to involve quite a lot of people, to sort of three levels of conversations with multiple people. So I sort of did a calculation in my mind, and I thought, well, you might have a lot of queries with assessments. So my question is that when you're looking at reviewing the budget, are you looking at how you can streamline? Is that reasonable to have so many layers of people involved in a decision that was really about semantics? In my view, yes, it needed a judgment call on whether you were going to cut this package element for this family or not, and that needs the experts to do it. But so many levels and so many numbers of people, and I just wondered at the cost implications. And the question is, are you streamlining that area?
So you will know we're at this moment in time in a financial emergency as a council, and we have put in many panels. I'm not going to call them that, I'm going to call them peer forums, to have a look at how we are spending our money, particularly across children and adults. So the majority of our budget, as you've already heard, is around spend on placements or around spend for people. So what we're trying to do is make sure that the spend that we are spending on individuals is the right amount of money. So yes, we should be out reviewing individuals. That's absolutely what we need to do. We need to sit, we need to review an individual package of care, and we need to support our social workers to make, or our adult social care practitioners to make the right decisions. What always happens is we then bring that back to a peer forum, which is what you've heard about. And that peer forum is about thinking about actually who else can do this. Because often what we can do is enhance those packages by using our voluntary and community sector, which is free support. And it's about making sure that our village, our community agents, whoever is in that room with us when we're talking about how we do it. Now, this particular case might or might not have needed that. And there's a question mark on that because I don't know the case. So that's what we do. What we've then put in is another layer, and it is another layer because we are now needing to scrutinise all packages of cares over, and I've got Emily online, I'm going to go for £350 a week. I think that's what it is. Yeah, that's right, thank you. Over £350 a week. And we're doing that in what we call an enhanced peer forum. They are running on a daily basis. They are about checking. They are about check and balance. In the same way as a whole council, we've put a spend board in. So anything over £100 goes to a spend board. So for children and adults, we've put these enhanced peer forums in to check that what we are doing is spending our money as well as we can. Now, we know that if we did go down a 141 route and became and declared that, we would have commissioners in, and commissioners would put this in place. So what we're doing is doing it early and doing it now to ensure, first of all, we're spending the right amount of money in the right way. That's number one. But secondly, to help our services to ensure that they're thinking about, as we always have in the past, actually, how do we best meet people's needs? It's not great putting lots of services in. That often disables people rather than enables them. And it all is about that re-ablement and that enablement. So that's the reason. I agree with you. There's a bit too many layers at the moment. I'd like to strip a few out, but right now, with a financial emergency and this being the biggest budget we have, we need to just put those in for the time being whilst we work some of this through going forward. I don't know, Emily, if you want to add anything to that.
No, I fully agree with that. I think it's also important to recognise that the peer forums are not just purely about cost. They're also about making sure we get the right outcomes for individuals. So the reason why there's multiple people there is so that we're getting the different experiences. So that may well be from an occupational therapist. It may also be from one of our community agents or community navigators that also support and look at alternative options to those paid services. I'm more than happy to share with you and I can quite happily share it with Jenny and others, the process, so that you can see the process and what we're expecting individuals to go through and our workforce. And I appreciate that there are layers, but at this moment in time, we have changed the financial threshold to make sure that we've got robust oversight of the adult social care budget.
And the other thing, if anybody wanted to join any of those enhanced peer forums, we have dates. They're every day of the week. You are more than welcome, if you want to just hear what's going on in those, to join any of those if you'd like. So we can do that as well. And they can join virtually or you can join in person.
How would we get that invite to that, please? And I do appreciate the comprehensive response. I guess my issue is about scalability, because I'm sure you've got quite a lot, many thousands of those assessments, and how much time it's taken. But I do appreciate you're between a rock and a hard place, because you, as you say, you have to do this in order to look at how to work through the budget and to make the efficiency savings. So it's not, I understand the challenge. Thank you.
What we can do is we can send to Jenny the dates of those, and you're welcome to make contact with us, and we can slot you into any of the ones that you'd like to attend. Not a problem. Just to get that, just so that you start to understand what sort of thing comes through there, that'd be no problem whatsoever.
Thank you.
Can I just refer members to pages 47 and 48? If you peruse those numbers, you'll see exactly why there has to be a dampening effect on the budget, and there has to be now. Any more questions in the room? I've got Councillor Sue Osborne would like to speak. Sue, good morning.
Morning, Chairman. From a very wet, soggy Ilminster. I may well have been able to get in, but my concern as ever is getting back home. As you say, it could be highly entertaining, and frankly, I'd rather not take the risk. I'll be one less on the road. Leaving that aside, my question is, and I'm not sure, I've got a couple of questions. I'm not sure whether they're relevant for this bit or for the bit where you're covering the transformation process, but I'll flag them up anyway. My first one was, I was at Executive yesterday and there was a paper produced on performance data, KPIs, about 112, not all adult social care. And I was wondering whether we should look at putting performance data or having an item on performance data for this committee to have a look at, because that's going to be very important going forward, particularly in the light of the consequences and the impacts of some of this work. My second part is, at the moment, one of the things that the performance report flagged up was that we have 800 overdue care reviews as against a target of 200. You've just described the panels and the process. How are we going to ensure that that backlog reduces, or at least doesn't get any worse? Because if people are doing the peer review work, they aren't necessarily going to be involved in getting that backlog down as well. And also I saw an audit paper yesterday, but not long enough for any detail, but it was identifying possibly risks around voluntary and community sector, which are going to be very important. And there's also another bit in there, which I'm not going to go into now because I've not had long enough to put it together. But it was identifying, I think, some particular risks around the voluntary and community sector, particularly as we're going to be relying on them more and more to deliver some of the reablement work. How are we going to sort of monitor that going forward? Because, as you say, there's crossover. So those are my two. I'm not sure whether they were relevant for this paper or might be better covered in the next paper, but I thought I'd flag them up anyway, so they're on somebody's radar somewhere. Thank you.
Thank you, Sue. The issue about KPIs will come to our April meeting when we've got a performance review. So you can't really do performance review without KPIs, I don't think. So that will be built in there. So perhaps Mel can answer the second question.
Yeah, so absolutely. We do bring our performance reviews every quarter anyway, so that comes normally and we'll do that. In terms of the overdue assessments nationally, and if you read the national picture out there, everybody has a backlog of overdue assessments. The challenge for us is how do we know within that assessment process who is at risk and who isn't. So we have a risk profiling that we do very regularly to manage that, to check where are we with that, what does that look like. And hopefully we get it right. We also have a plan to reduce those overdue reviews as part of that process. We get that monitored via our Safeguarding Adults Board, because it is a safeguarding risk if we don't know who's on there. And that goes to our Safeguarding Adults Board on a quarterly basis as well. So all of that we can bring when we talk to our performance. The second thing you talked about was the community. And you were referring to the finance paper that went to execs yesterday and was published the week before. And that talks about the risk of, if decisions are made as part of the financial challenge, to look at some of our communities and what we do in our communities that is perhaps non-statutory, is there a risk there? That will be picked up, I think, later on, but we are very mindful of how we use our communities, how we need to keep using our communities, and how important that is for the future of our services, and how we can continue to keep that prevention and early intervention services out there for not just ourselves, but for children and everyone else as well.
Yeah, thanks, Mel. As I say, it's just that it came up in, I think, the first audit paper I read, which was this, I think, risk assessment one, which had been done by Grant Thornton. And again, it's an example of crossover, and I was just wondering about, trying to understand, because there was a couple of red items on there, how that's going to impact on our performance and delivering delivering those savings, but also doing it in a legal fashion.
Thank you.
Thanks.
Any more questions from the committee? I think it's worth noting that there are two ways of looking at exactly the same figures. One is look at the amount of overspend, which is alarming and I'm sure gives Mel sleepless nights. However, there is the direction of travel is in a reduction of that overspend, and that has to be welcomed. However, there's still a long way to go, and there's not a lot of time. So thank you very much for that. And we move on to the transformation program, which I think is going to be, is it going to be Emily speaking to that? No? Yes? Mel,
yes.
speaking to that.
So I'll start, but I've got my, oh, we've got 2 likes on. So yes, but I've also got my, there you go. Okay, so yes, but I've also got Emily, well done. Emily joining me as well. So as you were fully aware, this is a program of change, our transformation program called My Life, My Future. But just a recap, we talked to people who draw on our services and some of our carers, and they were saying, actually, can you make this something that makes sense? Because this is about our future, this is about our lives, and we want to be integral in the design of this. Hence why we've called it what they wanted us to call it, which is My Life, My Future. Just to recap for those that are in the room that perhaps haven't been here before and haven't followed this journey, we as a council agreed to use Newton Europe, who are a consultancy firm expert in this area. They're one of the national firms in this area, to support us and to augment our care that we need, not our care, but the ability for us within the council to deliver. So because we've come together as one new council, we hadn't got the capacity and sometimes the capability to do some of these change programs that we needed. So hence why we agreed to ask Newton Europe to join us in this partnership. So what we'll do is we'll run through for you, and what we've also agreed when we started this program of change is that we'd regularly come here to update you. So whether that be twice a year, quarterly, we can have that conversation. But what we wanted to do today is just share with you where we've got to, what we're doing, and then take that forward. I'm going to stop now and hand over to Emily, and we may do a bit of a double act, but we'll take us through the slides. So could you put the slides on the screen, please? Is that possible for us? I know they are in the pack anyway, on page 69. Are they coming? Do we want to start while you're trying to do that?
I can get them up if that's easier.
Would that be better for you if we got them up for you?
Yes, please, Emily.
Perfect, we'll do that.
Just saying it's interesting to know they don't have heating in Taunton.
You're saving money, what you want about?
Still got that cold, so I'm lovely and warm, but other people are shivering.
Okay, we'll fire away now, thank you.
Does that come up for people?
Yeah, it's there. That's great, thank you.
Yes.
Do you want to take over and move on then? Yeah, great, thank you.
Yeah. So I'll start with the exec summary, but I think we'll cover all these points in the slides as we go through. So we are now 4 months, well, it's probably 4.5 now since we wrote the paper for this, into the My Life, My Future programme, and we've kicked off all of the work streams. All 5 work streams are now live, which I'll talk through in a bit more detail. We're starting to see some really encouraging early results in some of the earlier work streams, particularly around our reablement service. So our short-term support for people who've had some kind of crisis or intervention. And we're seeing more people going through that service in our trial area in Taunton and West Somerset. And we've also seen in some of our older adults residential provision a reduction in how many people we're starting new residential placements for. So our current performance is at a kind of value around 2 to 2.5 million of annual benefit if we could sustain that. We've got some really good financial tracking in place, and I know Penny and her team and some of the team around the business intelligence team as well have been working really hard to make sure that we've got the right tracking so we can see how these KPIs are moving and see how that translates into kind of financial benefit. But we've also got some risks around some of the benefit timelines, particularly around our kind of resourcing, and we've definitely seen some pinch points across some of our services and in our data engineering teams as well. The last point, again, which I think comes up in a bit more detail later on in the pack, is really conscious of some of the wider financial context. So we've done, particularly in the last month or so, a bit of a review of all of our work stream plans to work out what we could do faster, quicker, what could come forward in the plan to try and drive some more impact. And we've picked up some kind of work around the side on our placement rates of our residential and nursing provision in older adults as well, to try and work out, is there anything else that we could be doing to support further? So I'll start with the bit of an overview. So this slide just talks to, I think, what you covered in the intro, Mel, around what we really want to do in this programme is build on the strengths we already have in Somerset Adult Social Care to really deliver high quality person-centred services that are focused around supporting people's independence and well-being. And if we can support people to live more independently and not rely on statutory services, we should allow people to kind of live their most independent lives. So that's thinking about giving the right support to people in the right place at the right time. And those purple icons on the bottom there are some of the kind of principles we want to take forward in the programme. So person-centred, starting with outcomes for individuals, being really data and evidence led, so making sure that we are focusing on what does our kind of operational intelligence tell us. Supportive for staff, future focused, so thinking about how do we make sure that these changes are going to be resilient into the future as well. And taking an iterative approach. So lots of the work we've started is starting with trials in a particular area or in a particular team, where we test out a change of a new way of working, see if that works, make sure we can see the evidence coming through in those KPIs before we then roll out to the rest of the county. So you see, as we go through, we talk a bit about kind of trial areas and things. So that's really that iterative approach coming to life. In terms of the work streams then, so we've this kind of graphic on the screen now talks through our 5 key work streams. The kind of bars around the side talk about which teams they're impacting, but I'll give a quick overview of each of the 5. So starting with the yellow one, kind of top left in reablement. So that's working with our short-term service, which is reablement, which looks to support people back to a level of independence or the level of independence they had before some kind of crisis or event. At the moment, we typically provide that service for people on discharge from acute hospitals. But part of what we're looking to do is expand that service to support more people, both more people from hospital, but also those people who might contact us through our community routes. So how do we support more people through that service to get back to independence before we provide them with some kind of long-term service? The other part of that work is making sure that short-term intervention is as effective as possible. So how do we make sure we use the right support with our occupational therapists, the right kind of equipment, and the right kind of goals and plans for those people to make sure that they can be as independent as possible. The second work stream, the red one there, is our decision-making work stream. So that's really about how do we support our social workers and our adult social care practitioners to be as strengths-based and independence-focused as possible. Lots of the feedback we got through the diagnostic was around people feeling pressured around time or people not having all of the right information at their fingertips to make the best possible decision for that person. So that work is focusing on how do we support our practitioners to make those decisions. I think we touched on a bit earlier the discussion around peer forums, and Emily, I think, mentioned how do we get the right people in that discussion? How do we get different kind of professional expertise in our occupational therapists, but also how do we get our community and village agents and some of those more voluntary services in that discussion as well, to really explore what is the right thing for that person and how do we keep them as healthy and independent as possible. The kind of teal coloured one on the right, progression and enablement, that's focusing on our adults with learning disabilities and how do we make sure that we've got kind of progression and forward-looking plans for that cohort so that they can gain new skills and kind of progress towards a more independent life. So one of the things we found in the diagnostic, we support those people well now, they're safe, well, their needs are met. But how do we think about what does the future look like for them and how do we keep them moving towards a more independent life? Linked to that, the orange one at the bottom, the preparing for adulthood, that's specifically looking at our cohort of people who turn 18 and move across from children's to adult services. So all the same principles around progression and enablement, but specifically for that cohort who are moving across into adult services. And then the fifth one, that purple one, is one that doesn't have a kind of operational KPI attached to it as such, or a financial value attached to it. That is our data visibility and control work stream, and really focusing with our performance and business intelligence teams. How do we get the right information to the right people in our service at the right time? So not having lots of different dashboards or not having no information, but how do we get something that's really actionable and the right data to those people to make the right decisions? Is there anything to add on that, Mel, before I move on a bit? So what does this mean in terms of kind of financial opportunities? So you can see the 4 work streams that have the kind of financial opportunity are the ones on the screen there, so not including data visibility and control. Each of those then has a financial value attached to it, has a target and a stretch. So those values came from the work we did in the diagnostic to really try and understand the scale of the opportunities. So our target is what we're aiming for. Our stretch is the kind of with everything going our way and with the best possible outcomes, what do we think this we could reach? All of these values essentially come from impacting our long-term spend. So different areas of our long-term provision spend with our older adults, our learning disability, or our wider adults cohort. And so lots of them are about how do we support people to live more independently and rely less on our statutory services, and that impacts our kind of long-term spend. The table you can see at the bottom, it is the kind of profile of those values through time. Because lots of these opportunities come from supporting people in a different way, there's a kind of duration element to how long someone's package lasts. So what we don't see is if we make a change on day one, we don't see the full value of that change on day one, because that person might be in our service for a year and a half, 2 years. So that profile table on the bottom just speaks to how these values kind of accumulate through time. So you can see into the kind of financial year 27 to 28 range is when we're up to full kind of complete run rate. We hit a significant kind of up towards that 10 million number in 24-25.
Shall I just jump in there? So what we're trying to say, just to make it really simple for everybody, we know that if we do things different, we keep people at home longer, which is what this is all about, keep people independent, because as you know, not many people, me, any of us, our families are really looking forward to going to residential or nursing care. It's at the top of our priority list. We want to stay in our own homes. But actually, if we stop people going in, we've already got people in. And normally people stay in a residential care home for about, or nursing home for about 18 months is normally the lifetime in that. So the spend takes a little bit longer to come out. So if I stop people going in, I'm still spending on people in those care homes. So as they leave those care homes, or as they become to their end of their life and die, actually that's when the saving comes in. So that's where you start to see your stretch targets, and that's where you see to start the money coming into us. And that's the pieces that we start to look at. In terms of learning disability, it's not quite the same, but it's actually a reduction in some of the high cost packages that we have, because actually we're making people be more independent and live the lives that they want to live, whether that be going into work opportunities, whether that be coming out of residential care into a more independent way of working. So that's the types of stuff that we're looking at, and and are already seeing some of the results of. I'll stop at that point.
Thanks, Mel.
Members, Germany, are you? No, carry on.
Sorry, I'll do this slide and then I'll do a check for time, because conscious I don't want to take too much and ruin your agenda totally. So the last slide I'll talk through for a quick pause is just to talk about the kind of contingent fee mechanism that we're working to on this programme. So you've seen the kind of opportunity values on the previous slide, that our kind of target is at the 14.2 range up to the 17 million as our stretch target. The way that the support from the Newton team works is that we provide this support on a contingent fee basis. So we've got in our contract a guarantee that says we will guarantee that we exceed 1.3 times the fee for our kind of team and our time. So we've got a guaranteed benefit of £10 million. The way we're measuring these benefits is for each of our kind of operational areas, we've got an agreed historic baseline, which we are then comparing our current performance to. And then we've got a set of kind of agreed equations that translate that into our kind of run rate for the programme. So that run rate value is essentially, if we could sustain the performance we've reached indefinitely, that's the value of it. If at the end of the programme we haven't exceeded that 10 million, either the Newton team continue to work at no extra charge until we've reached that value, or we reduce our fee pro rata down to make sure that we always keep that 1.3 times guarantee. In terms of timing for how long we've got for this slot, should I carry on through the rest of the slides, or is it worth pausing for questions now?
Nobody's jumping in with questions, so please keep going.
Okay. So programme plan, you can see this is our kind of 5 work streams through time. So you'll see it's talked through in that iterative approach that we've split each work stream into kind of what are our trials. So where are we going to test some new ways of working? And then once we've got to a set of trials and a set of changes that we're confident work, how do we then adopt and sustain those across the rest of the teams or the rest of the county? What you'll see in our learning disability work streams, so in their work streams 3 and 4, is we've got that kind of dotted bar in there around short-term financial emergency support. What that practically means is we've moved some of the planned activities around in that to make sure we're really supporting the activities that drive value in the short term. So as an example, with our Preparing for Adulthood workstream, we are now focusing a bit more on our 17-year-old cohort, as they're the people who will impact the adults budget soonest, rather than the very early version of the plan, which started a bit more at our 14-year-old cohort, for example. The red bar you'll see on there in around our data visibility and control workstream is we've had some resourcing issues around the data engineering capacity within Somerset Council. We've got a really clear set of mitigating actions in place for this one now. So I think we're happy that we've got a way to get back on track with this one, but it's still flagging as red just because those mitigation actions are kind of early in train. This slide then just talks to where we're at currently in terms of our value add and run rate. So there's two kind of sets of values we're tracking in the programme, and Mel, you're sick to death of this slide because you see this near enough every week. So the cumulative value add is essentially our cash position for the programme to date. Those numbers are still really small as we're really early on in the programme still, and that cash accumulates through time, as we talked about that duration factor. So these numbers are still pretty small, but reablement, we're a little bit behind, and then our outcomes from decision making, we're well over our kind of target value. I think the more important one at the moment is that darker blue, that run rate slide. That's the one that says if we held the position we're at now, what would this be worth in the long term? So you can see again, slightly behind in our reablement one with our, but we've got mitigation actions in place, but really overperforming on our outcomes from decision making side. So that's driven by our residential starts, as in the number of new placements we make into older adults residential. We're already at target for that. So the activity now is really about how do we sustain that.
Do you just want to just give them a couple of examples of perhaps the reablement model you could come into anyway?
Yes, yeah. I'll do the next two to just try and bring to life some of the practicalities of what's actually happening, and then I think we'll pause there. So taking our reablement opportunity, when I've said we want to put more people through this service and we want to make this service more effective, that sounds fairly obvious and fairly simple. The set of things that need to change to make that happen, there's a whole level of complexity in both in our kind of processes and in some of the culture and behaviours. So trying to break that down a bit more into our reablement service. So firstly, we need to make sure that our teams and the NHS teams within the hospital are discharging people to the right setting. So how do we get more people being discharged to our reablement service, which involves changing how does the hospital staff have a risk appetite for discharging those people home rather than to a short-term bed? How do we support our NHS colleagues and our system colleagues to change some of that behaviour? And how do we make sure that people feel kind of supported to take more of those potential, what might feel like a risk around where do people go from hospital? Even if we do that, we need to make sure we've got enough capacity in our reablement providers to accept those people. So some of our trials, and the one I'll talk to on the next slide, is around how do we make sure that we free up enough time from our reablement providers to support those people? Because even if we can get to the point where we've changed those behaviours, we need the capacity in that service to meet that extra number of people. So there we're looking at how do we progress cases quicker through the service, and how do we look at different scheduling and rostering practices with our providers to get the most number of effective hours from the staff that they've got. And then even if we do that, we need to make sure that the reablement service is as effective as possible at actually impacting what people go onto in their long term, and how do we minimise the kind of statutory support or home care that they'd need in the future. So a lot of that is focused around how do we have the tools, processes and behaviours around setting goals for those people. So we're not just supporting them, but we're actually saying we're going to support this person to relearn how to get out of the chair, make a cup of tea and make their own lunch for themselves. How do we break that down into a set of goals that we can achieve over that 2 to 3 week period, really targeted and focused work with that person, not just we support them to make lunch and we go and make their lunch for them for 3 weeks. That second point on the capacity side then, so one of the, just to do a bit of a deep dive in one of our trials, is around our kind of grip and visibility of our caseload. So practically what we've changed with one of our providers in Taunton and West Somerset is how do they manage their caseload. So making sure, to those key principles on the left, we've got a description of what each person is trying to achieve. We have a caseload tracker, so essentially a kind of tool that makes sure we're tracking what that person's doing and what their next step is. How do we have kind of the right meeting structure around that to drive those actions? So we don't just know what's happening, but someone's taking and owning the action to take the next step for that person. And we're reviewing our key KPIs with the leads in that team. So we're constantly looking at how long is our length of stay in this service? What are the biggest blockers to that length of stay being shorter? And how are we actually taking action on some of those? So the quotes there are just some of the positive feedback we've had from providers around being able to see caseloads, being able to see the goals and visits at a glance and know what you do, but also some of our therapist support. So making sure that we've kind of got that expertise being used in the right way for those people. And into this trial, we've seen a 20% increase in the number of finishers of the reablement service through this area. So we're getting 20% more people through this service with the same number of hours from our providers. So what that means is we've unlocked that capacity. Now the next step is to make sure we're getting the referrals into that service to use that capacity that we're freeing up.
Emily, can I just interrupt you just a second?
Yeah,
Can I just
yeah.
clarify that you're talking about reablement that's provided by providers directly for Somerset Council?
Yeah.
And that's fine. Do we also look at the reablement situation that goes on when people go into hospital? Because I have a concern that some people are coming out of hospital after apparently being reabled, actually less able when they arrived in that hospital. If it hadn't happened 3 times, I wouldn't have been concerned. And that's costing us money later. We're focusing on one, but are we also somehow looking at what our friends in the NHS are doing?
So often, you know, this is a program of change for adults at this moment in time. Yes, it means we work at system change. There is work going on which starts to think about when somebody comes into a hospital, what do you need to do to help them to leave pretty quickly? So for me, a hospital isn't about reablement. Getting fixed and getting out as quickly as you can back to where you came from. Because without a doubt, when you're in hospital, you sort of get then, and people say, "All right, I'm in hospital now. I'll put my pajamas on. I'll put my clothes on, and I stay in bed because I'm ill, and I don't get up." Well, you wouldn't do that at home. So the challenge for our hospitals is how do we ensure that people are getting up and moving as soon as they can when they're in hospital. So if they've had a fall, they've broken their hip years ago, you'd have stayed in bed for days, but you now get up and get moving and get out pretty quickly. So the challenge is how do we ensure that you are doing that very well in your hospitals? It's not an easy cultural shift, and it takes time, and we don't always get it right, but we're trying to do both ends of the spectrum, not through this program of change, but actually together as a system, as part of our ICB. Yes, we are looking at that, but it's not quick work.
Do you want to continue, Emily?
I think we're probably there, aren't we, with where we need to be, and you've got the rest of the information.
I think the last 2 slides have probably touched on the key points around some of the risks and some of the changes to respond to some of the financial context. There's probably not any new information that I haven't already touched on in those 2 slides.
Thank you very much. Members, hopefully Councillor Whale now has a clear idea about what Europe is about. Councillor John Bailey and then Councillor Hilary Bruce.
Thank you, Chair. It's in relation to a clarification on page 73, all the way through. You referred to 5 areas, I can't recall them, but reablement, etc., etc. And on that page, You only put 4 down. And it was the one that was missing was the data. I'm just going to go back to it now so I can recall it. And I wondered why, yeah, 73. Data was missing in terms of the financial opportunities. And I just wanted a clarification on that.
So data isn't about financial opportunities. I think you've still got your mic on. I don't know if you want to flip that off. There you go. So data isn't about savings opportunities. It's sort of a cross-cutting piece of work that says, actually, if we get the data right, the data will help my teams and all of our teams understand that what they're doing is working and actually help them to make decisions. So it's not got a monetary amount next to it. It's really about that cross-cutting theme. As you'll know, if we get our data right, we get our performance tools right, we make sure our teams are using that, we then drive out efficiencies. And that's what that's about, rather than, and then we've put the funding against the other models. Does that make sense?
Yes, it does. I thought that might be your answer. Thank you very much.
Thank you.
Councillor Bruce.
Thank you. I'm hoping Mel might be able to help me understand a little bit better, put it in layman's terms for me. The run rate. So it's described as being the financial value realised if this operational performance were to sustain indefinitely. Is this run rate a benefit that's an annual thing? I find it strange that that's put into a figure. How long is that benefit going to go on for? I'm a little bit confused by it. Can you help?
Yeah. So when we do a run, Emily, I should be trying to let you do this. When we do a run rate, it's about us tracking. So it's about us being able to track what the ultimate aim is. But yes, it will be a continuous figure that continues on and on and on. So if we get this right, that should be a savings going forward. Now, what it doesn't take, but what it's based on is the baseline we started on. So if, for example, we have 100 more people come into the service, as long as we're using this methodology still, we will see a decent run rate, but that could, so it's not going to affect this saving because this is an ongoing saving. It can then also help us predict future savings in that space. But this program is based on where we are now, or where we were when we signed it off, which was a couple of months ago, and where we expect to be. So that's what that run rate is based on. Does that make sense or not? No.
Sorry. Okay. Yeah. Thank you.
Is that okay? Yeah.
Yeah. Thanks.
Great.
Any more questions in the room? Councillor Sue Osborne.
Thank you, Chairman. Just a couple of questions. Some of them are probably, one of them is fairly basic, I guess. Paragraph 325, you're talking about data. What's the difference between data-driven behaviours and evidence-based decision-making?
Probably very little in practicality. There are probably two ways of describing the same thing. So essentially what we mean is that, so if I had to go back to that reopening example, giving the person who leads the Taunton and West Somerset team the information at their fingertips to say our current length of stay is 19 days, and the biggest reason that we could get that lower is that we need to make sure that these 3 people get referred to the equipment service as quick as possible. So it's about rather than that meeting going, oh, could our length of stay be lower in this team? Maybe it's this, maybe it's that. It's giving the people who can action something the really clear information to say it's this thing that we need to go away and change. And next week we should see that length of stay number go down.
Okay, thanks. So you could potentially use those interchangeably because they're very similar. That's
yes,
fine.
yeah, essentially.
Clarify, because you don't want, as you say, get into an argument over semantics. And my second question is looking at the programme plan and the delays that are on there and the need for short-term financial emergency support. How are those delays, if they're not rectified, going to impact on the financial savings, impact on your targets, and what steps are you making to ensure that it doesn't impact, or at least adversely impact?
So the two that we've got the kind of that dotted bar in for, so are the learning disability progression and enablement and our preparing for adulthood one. So it's like slightly different answer for each of them. On the preparing for adulthood one, I think if anything, we are focusing on bringing savings forward on that work stream. So I'm not concerned about that one in terms of impacting that 10 million in year 2 figure. Essentially, we've started with the biggest impact people first. So we've started with our kind of 17-year-old cohort rather than making our longer term changes sooner with our 14-year-old and 15-year-old cohort. So that one I think should have, if anything, a positive impact. I think the learning disability progression and enablement work, the work that we've got in the plan is complementing existing savings activity that Mel's team are doing around our high cost reviews and our out of area reviews. So it's how do we take learnings from those, feed them into the longer term progression work, and as our total savings, the number should go up. What we might be doing is just adjusting how much is high cost reviews in the savings plan and how much is the programme work, but the total quantum of savings, I think we're trying to drive that number higher. Does that make sense, or is there anything you'd add to that now on that LD side?
No, I think what we've done is there's always that challenge, isn't there, about how far back do you go? So I'd really like us, we wanted to start, ideally you'd start at 14, wouldn't you, with people, so that progression through to people, we got it right. But actually, because we know we've got a financial issues here, so let's make the best buck we can now. So start at 17, because they'll flip over to adults, and then go backwards. So all that will get us a bit more money sooner. But we need to make sure that we don't leave it at that, and that we still go back to 14. And that's the bit, because we have to get it right there, because that will help savings in children as well as in adults. So we need to do that piece as well.
And we want to make sure that we learn from the work we do in the short term, so that it makes the longer term work that we've pushed back in the plan more effective. I don't want it to be a kind of totally different set of activities. It should be a learning exercise for us as well.
Yeah, thank you. So what you're saying in effect is there shouldn't be too much impact on your programme of delivering savings from any delays in these programmes. That's what I was trying to check. The other bit, and I'm curious, is how is the micro provider sector going to fit into all this? Is it going to be enhanced in any way? How are they involved?
So in terms of our decision making, part of our decision making is about what have we got out there? Have we got the right environment out there? What's that looking like? So that isn't impacted with this programme of change, but actually, as part of that, we're looking at, have we got the right, are we commissioning the right services? What do they look like? And micro providers are a really important part of that. So we continue to work with them, we continue to do that. But what this then does is you'll know, we do an assessment and we'll do a support plan, and then we'll say, okay, this is the amount of money, the personal budget that person has. How that person chooses to use that budget is where you get the micro providers in, because some may say to us, actually, we don't want a direct payment to do this. We want you to manage it for us. Or they may say, we'd like to do that ourselves. And if they'd like to do that themselves, then they often meet some of those outcomes by using micro providers. So that continues, and that's just part of our commissioning process.
Okay. Okay, thanks, Mel.
Councillor Hilary Bruce.
Thank you. I'd just like to say that the update is really welcome on this programme. Direction of travel seems to be quite positive, which is lovely to see something positive coming forward. I just wanted to know when the next update will be. I think it is something that we still need to scrutinise quite closely. So could you let me know when the next update will be, and we can add it into the work programme? Thank you.
And I think that's about how often would you like it? Do you want this on a quarterly basis? Do you want it on a 6-monthly basis? What would you like? And I think we can do that, because I see it every week. So, it's not difficult for us to produce this.
I think quarterly is, at least quarterly is the appropriate time. We can't go any longer than that. This is such an important focus. If members are happy with that, it's not my decision. Okay, any more questions? Can I thank you for the presentation, because I think there was a clarity there, or a bit more detail about how the process works, and is incredibly important to the whole council at the moment, that we make this progress. So thank you very much, Mel, and thank you, Emily.
Thank you.
Thank you.
Stroke services, yes. Right. I think we've got Julie Jones, who's going to talk us about the results of the consultation on stroke service. And members will bear in mind the comments that were made by Ray Tosterman at the start of the meeting. So, Julie.
We're here to do two things. One is to just give you an update on a summary from the consultation, but also to give you an update on where we've got to as far as the stroke work is concerned. So I should have with me Sarah, who will just give you a quick update and summary on the consultation, but also joining me is David McClay. David, I don't know if you want to introduce yourself.
Yeah, good morning, David McClay. I'm the exec lead for digital strategy at NHS Somerset. Nice to meet you all.
And I'm hoping I've got Dr. Whiting with me, but he may be busy clinically, but it looks like he's with us.
Hi, I'm Dr. Rob Whiting, I'm a consultant stroke physician at the Scrutiny Hospital.
So I'm going to let Sarah go first, and then I'll just run through the paper that you've had, if that's okay.
Hi there, I'm Sarah Bonfanti. I'm the head of communications and engagement. Have I got feedback there, or is it just me? Is that better? Yeah, brilliant, thank you. So I'm the head of communications and engagement at NHS Somerset, and I've spoken to you before about the stroke services consultation. So we're just bringing back some of that insight that we've gathered around the consultation and what we're doing with it at the moment. So you would have all seen the paper. So that's the You Said We Are Doing and the consultation activity report. So that was part of the appendix to Julie's paper. So hopefully you've all had a chance to look at that. And what that does is that highlights the range of ways that we reach people during that 12-week public consultation, and also then provides an overview of the number of responses that we had and the themes that are arising, and then what we're doing with them. So as you'll know, people are invited to give their feedback on the proposals that we took out to consultation, and we used a range of methods to reach those people. So we worked with an independent research organisation and the Consultation Institute as well, to make sure we were following best practice and going out and looking at who we needed to reach and the best ways to reach them. So what you'll see in that activity report there is the different ways that we did that, and then how during a midpoint review we then also amended our approach. So really looking at who we weren't reaching and who wasn't responding during that feedback, to then look at how we could tailor our activity a bit more to get more responses from those particular communities. We also worked with Opinion Research Services, so that's the independent research organisation ORS, to run a representative telephone survey. So that was targeting people in Somerset and the surrounding areas, and matching it to the demographics of Somerset and those surrounding areas, to again make sure that we were getting those responses from those wide range of people. So not just the people who chose to do the survey and the questionnaire that was online, but also phoning people and contacting people that perhaps didn't know anything about the consultation to get their responses as well. So we had all those different work streams alongside the interviews and the focus groups that again ORS ran for us, so that we have those wide range of responses from all those different avenues using those different methodologies. And from on page 2 of the report, you'll be able to see the different methodologies that we used and how the different responses that we had from those routes as well. And ORS at the moment, they're going through all of that feedback and looking at it, and that's then helping to inform the work that Julie and the programme team are doing around the decision-making business case. So that's where you'll see on the next stage of the report the kind of the key themes that we've heard and what we're currently doing looking at those. So key themes were around transport and travel times. So particularly concerns around how the increased travel times may affect people if it takes them longer to get to hospital. and then different suggestions to make it easier for people who needed to travel to visit their loved ones, and different things that we could potentially look at to help people get to visit their loved ones more easily. And again, the programme team and the steering group are looking at all further analysis around the travel times and doing a deeper dive into that travel time modelling to look at how we can take that insight into account and really explore what people have said. Then again, another key theme we heard was around quality of care, and that was again predominantly around concerns that could it be that patient outcomes could be worse again if they didn't get to hospital quickly, and also if we struggle to provide the workforce that's needed, could that impact the quality of care as well? So we saw some questions raised around that and concerns around how that then might affect people's outcomes in the future. So again, that's something that more detailed modelling is taking place to look at around the decision making business case, the DMBC. We heard concerns around equality of access. So this was more around people who, if they needed to visit loved ones in hospital and it was a bit further away, and they needed to use public transport, how that then might impact them. Particularly, we know with some of the more rural areas of Somerset and people who are on lower incomes as well, and how they might impact them. So again, that's all been incorporated into our equality impact assessment, and our equality lead is looking at all that with different groups of people who were particularly highlighted as groups that people felt might be more impacted as well. And then we heard concerns around inpatient environments. So this was a lot of suggestions of things that we could look at. So again, this is about making it easier for people who potentially might have to travel further to visit loved ones. So it was things like, could we make better use of technology, like using iPads so that people could contact their loved ones more easily and things like that. So again, that's something the steering group has reviewed and is looking at all of those suggestions. And they're undertaking a review of the options that might be available to people as well, based on that feedback that we're hearing. And then another key theme was around workforce. So this is about concerns raised about the potential impact on staff. And again, this is something that the programme team are looking at in quite a lot of detail in that decision-making business case. So part of that next stage of modelling will be looking at all of those things and taking those concerns into consideration. So the insights that we've got at the moment from ORS, we're still going back to them and getting more detail on some of those aspects and breaking it down in different ways. But that's being shared with the steering group and with our patient and public stakeholder group as well. And we've talked through it with them and getting more insights from them and kind of understanding things a little bit better. And then that's all being used to inform the decision-making business case that the programme team are working on at the moment. And then I'll hand back to Julie.
Do you want to answer any questions from Sarah first before I go into my paper? Ask any questions?
Sorry, members. Do you have questions about the very interesting paper that's before us at this point, or do we want to hear a bit more from Julie first? Questions at the end, yeah.
Okay, thank you. So the paper provides an update since the 12-week public consultation and describes the next steps which we've taken to decide on the future of acute hospital-based services. So just doing a bit back to the background, in 2019, a review of Somerset stroke services was carried out, and a key recommendation from this strategy was to review the way hyperacute stroke care and trans-ischemic attack services are provided in Somerset, and that's a mini stroke. So the main reasons for needing to reconfigure hospital-based stroke services were around challenges with recruitment and retention of specialist staff, failure to meet national targets around hyperacute and acute stroke care, both in Taunton and in Yeovil, variation in the service across the county, particularly at weekends and out of hours, and also opportunities to reduce the cost of long-term care associated with stroke by improving the outcomes in the hyperacute phase. So it's widely accepted that to make a hyperacute stroke service clinically sustainable, maintain expertise and ensure good clinical outcomes, 600 stroke admissions a year are required. This is achieved in Musgrave Park Hospital. However, Yeovil District Hospital does not achieve the required yearly numbers to deliver clinically sustainable services. We've also engaged with and involved our neighbouring healthcare systems through the development of the change, and particularly as the biggest impact is on Dorset system, they've been present at our steering group and our clinical reference group alongside the ambulance service. The process of developing the original options had input from local clinicians, staff, people with lived experience, community and voluntary sector partners, and colleagues from neighbouring healthcare systems. And we started with 9 options and tested them against a set of hurdle criteria using the pass or fail score. We asked a range of experts to review the long list, and we shortlisted to 6 options. The 6 options were then reviewed by the stroke steering group and was reduced down to 4 options based on clinical safety. The final 4 shortlist options were assessed by a clinical review panel of the South West Clinical Senate in September 22, and the panel deemed that there were 2 options with a strong clinical evidence base that they could be assured would address the reasons for change. These were the 2 options that went out to public consultation, and just to remind you of those, the option A is centralising hyperacute services at Taunton, so that's the first 72 hours of someone having a stroke, and then having an acute stroke unit at both Yeovil and at Taunton. And option B is having all of the stroke beds at Taunton, so all the hyperacute and acute stroke beds would be at Taunton, and there would not be a service at Yeovil. So since the consultation, you've heard earlier about the USED and we are doing report and the actions being taken, and we're doing more detailed analysis and modelling for the 2 options. And since then, several areas were identified as not being available at the time of starting the consultation. The 2 main themes were significant concerns about the role loved ones play in recovery, increased travel times, supporting visiting families with parking costs and accommodation, and concerns around the current ambulance waiting times and delays in getting treatment. The second one was delivering the entirety of option B at Dorchester County Hospital would not be possible and would require significant capital investment and could not be delivered in the 2-year timescale set. So we set about a process for assessing the viability of the 2 options that went out to consultation. And the process of assessing the viability of those 2 options were done in the same way as we did when we assessed the 9 original shortlisted options down to the 2. We also used the pass-fail scoring in assessing the options, and we used the hurdle criteria, which are in the paper that you've got on page 7 and 8. Information on the financial impact was not available when we undertook the initial options appraisal. However, on reapplying the hurdle criteria to the 2 remaining options, we've considered the financial implications of both options. The same range of experts were asked to review the 2 options, and the directors of finance within Somerset Integrated Care System with their Dorset colleagues have worked together to understand the financial impact of the options. The reapplication of the hurdle criteria to the 2 options demonstrated that option B was no longer viable, with more fails than passes on the deliverability element, travel times for carers, and workforce sustainability. Further analysis on travel times showed that a higher proportion of Somerset residents would have an additional 20 to 25-minute drive time. Support for providing stroke care at both Taunton and Yeovil was strongly heard through the consultation feedback to provide local services. The financial modelling has included more detailed analysis by Dorchester County Hospital. Indicative elements for capital money for option B is approximately 7.8 million. However, this would still not provide a total solution on the Dorchester County Hospital site for a 38-bedded stroke unit. Therefore, Dorset Integrated Care System cannot support option B. The capital money required is 25% of the Somerset system's capital allocation, and so investing this money in stroke means that we could not invest in other acute primary areas. The indicative capital costs of option A are 3.5 million, and while this would impact on the other areas of the system's capital programme, it's more manageable than option B. The indicative revenue costs at Dorchester County Hospital of option A is 2.63 million in comparison with 3.2 million for option B. And the indicative costs for Somerset Foundation Trust of option A are 2.1 and option B 0.9. So we're saying that implementation of the bed requirements under option B is not deliverable at Dorset County Hospital and could not be implemented within the 2-year timescale set. And if you put that alongside the strong public voice that we heard through the public consultation around the adverse impact on families and carers if stroke services were completely removed from Yeovil, a recommendation was made to the ICB board to discount option B and to work with a preferred option, which is option A. The Somerset board, ICB board, discounted option B last week and agreed to take forward option A as the preferred option to be modelled in more detail. It's important to note that no final decision has been made, and based on the modelling work so far, there is only one deliverable option for the future of hospital-based services, and that is that there is one hyperacute unit in Somerset and an acute stroke unit in both Taunton and in Yeovil. Make sure that, just to say, the final decision has not been made, and we envisage that to be done in January at the ICB board.
I have a feeling members may have some questions. Thank you. Councillor Sully indicated about 4 minutes ago that she wished to speak. So Councillor Sully, and then it'll be Steve Ashton, sorry, and John Bailey.
Thank you very much. Interesting reading. So my question is 2 parts, really. It's widely accepted to provide sufficient patient volumes to make a hyperacute stroke service clinically sustainable. You need 600 stroke patients. So I just want to understand that a little bit more, what that means, because each person is, one person is a stroke patient. My mother-in-law is currently a stroke patient there, and she had a heart attack, and she's currently in Yeovil Hospital, so it's quite close to home at the moment. And we need to prioritise stroke patients. Under the proposal, there's going to be areas of Somerset, in my view, that are going to be disadvantaged with, as you've acknowledged in the feedback consultation, with where they are. So as the first question is about explaining this number, because it's demand-led service, it's going to grow, isn't it? That demand is growing. We know that. So first question, to understand that a bit more, where you get to that number, and why that number, what it actually means. And 2, is this going to be a postcode lottery for Somerset when it comes to their treatment when they have unfortunately have a stroke? Thank you.
So I'm going to ask Dr. Whiting if he can explain the 600 patients a year. That's okay first.
Can you hear me okay?
We can hear you. Please go ahead.
Thank you. So the evidence around the threshold for the number of patients seen by a service is around the ability to do the intensive sort of hyperacute treatments as quickly as possible, and evidence from national audits, such as the Stroke Centre national audit, have shown that what's described as large volume centres that are doing these treatments more frequently are able to do them more quickly and more safely. And so that's where the threshold of having a stroke service which admits between 600 and 1,500 patients per year. So yeah, that's the evidence for that. What I'd say is the number of patients also is important about having a service of a sufficient scale to have enough consultants to work in that service. So stroke services who admit fewer than 600 patients per year are less likely to have sufficient stroke consultants to be able to manage that service 24 hours a day, 7 days per week. And so having a larger scale of a service enables you to have the funding and the financial stability to have enough consultants to manage a service that's sustainable. So that's the other point.
Sorry, can we just come back on what the Yeovil number is? How much short of the magic number it is? It's averaging 400 a year.
I think it's about 400 per year.
400 a year, yeah.
But what I'd say is they have one stroke consultant and one vacant post, which is filled by a locum, and that's not sufficient to man a 7-day lead hyperacute stroke unit. There are clear standards around what a hyperacute stroke unit should deliver in terms of its frequency of assessments and ward rounds. And I think it's important, if you have a hyperacute stroke unit, that you deliver those standards. Having a hyperacute stroke unit which is by name but doesn't deliver those standards, I think also would introduce a postcode lottery for our patients.
I listened to your answer. I did find it a little bit confusing, but I do want to make the point about the growing demand for that. So the difference between 400 and 600. But the second question was about the postcode lottery. Do you feel there will be a postcode lottery? And I'm going to sneak one in about the workforce plan, because it does seem to me at the heart of this is about recruitment. And just diving back, what happens if Musgrove becomes, there's too much demand at Musgrove, because the numbers as they increase, they will then, isn't it better to have it more balanced out between the two locations? Still not really making sense, this decision, I'm afraid to say, to me.
So we know that, I guess, trying to break down the journey of a patient who's had a stroke. There's a time which is the time before they arrive to a hospital to have treatment, and that's where, as is mentioned by Julie Jones earlier on, there'll be areas of Somerset who have to have a longer travel time, sometimes up to 20-25 minutes. What we know is that units who are doing treatments such as thrombolysis more frequently do it more quickly. And what I say is, I've done an audit of performance that happens at Musgrove Park Hospital for thrombolysis. What happens in both units currently is 9 to 5, Monday to Friday. There's a stroke consultant who will assess them as soon as they arrive. Outside that time, from 5 p.m. until the following morning at 9 a.m., it's usually a medical registrar who will have to assess them amongst all the other things they have to do. And they are less experienced in assessing patients who've had a stroke, and they then need to contact a specialist on a network. I'm on that network, which introduces longer times and more delays. And the audit we've done at Musgrove shows that the time from arrival in hospital to actually delivering thrombolysis is at least 30 to 35 minutes longer when delivered by a non-specialist, non-consultant. And also that if we can extend the hours of a consultant being present in the hospital to cover the weekends, and also 8 a.m. to 8 p.m., 7 days per week, over 50% of those patients who be assessed by a non-specialist medical registrar would actually be assessed by a stroke consultant. So all those patients are much more likely to get their treatment much more quickly when assessed by a specialist. And so increasing the hours of coverage will help to address and to mitigate the longer travel times, but also be beneficial for every other patient who arrives to hospital in that time frame. Regarding the question around the trust being overwhelmed, we've taken that into very careful consideration when doing the planning. Already at Musgrove Park Hospital, there's been some move to expand the stroke service. So we did just have one ward, which was called the Dunkery Stroke Unit. It's actually now across 2 wards called the Dunkery Stroke and Neurology Unit. So we already made plans to expand the scale of the service. We've done very close working with our radiology teams around capacity for the scanning, and that's not felt to be a barrier to this change.
Steve?
Yes, I have a number of concerns here. First of all, it appears that your closing down the Yeovil HA unit for a unit in Musgrove that has, according to the Sentinel reports, has poorer outcomes than Yeovil. So you have a Yeovil has better outcomes, Musgrove has poorer outcomes, and you're planning to close the better one. Secondly, the Senate report on this criticises your modelling, that it's blue lights at 3 o'clock in the morning, and that doesn't seem to have been addressed at all. The 20 minutes is commonly quoted here as for a trip from Yeovil to Musgrove. I mean, you can't do that at any reasonable time of the day at all. Thirdly, the ambulance category 2 response times is appalling down in the sun, and you're adding extra time on top of that. And if thrombolysis has to be administered within 3.5 hours of onset, and you've got a 3-hour response time from the ambulance service, this 20 minutes just takes most people out of that window. Additionally, the PPG chair's letter to this consultation hasn't been responded to or hasn't been addressed at all. Stroke ambulances weren't considered. And then the consultation here. The consultation, most people's concerns are about closing the HASU unit at Yeovil. And you've gone and said, well, we've put up consultation, we've addressed people in public toilets, and we've done this and done that. But the question that wants to be asked is, can we not close the Yeovil unit? And that just, so the consultation is completely pointless. It's a complete whitewash, the consultation. And I think what the knock-on effects from this is that we will end up with poorer outcomes. I mean, okay, some people will die on their travels to Yeovil, so it's a small saving. But adult social care will pick up the pieces, pick up the damaged people that come out of this system from this appalling process here. I find myself exasperated here. It really is terrible. And when I was a governor of YDH, it was hammered into us that this is not anything to do with the merger, nothing to do with this. This is a completely separate track. But that was just a lie. It just was a lie. I'm sorry. I'm sorry. I've not placed this as a question, but it's just a number of concerns that have come to us, and a number of concerns that have come to me as a councillor about this in social media everywhere. It just seems to be this is a decision that's already been made, and we're just going to ram it home.
Councillor Ashton, I think if we could try not to refer to lies, there are factual inaccuracies and we can draw them out of the report. But if we try and, this is a very emotive subject, and I'm going to do my best at the end when I speak to be calm and rational, but I don't guarantee I will. Questions, we've got some very knowledgeable people available to us. Questions from the members. John Bailey.
Thank you, Chair. Well, 2 hours of questions, but firstly, thank you for your presentation. I would have found it easier to understand with some slides as we've had with previous presentations, because I found it difficult to, having read the report beforehand, to keep up to speed where everybody was. And I think the bullet points that I found useful, but that's a broad point there. It seems to be there's some review after the consultation, but I've got 2 hours of questions. What's this 600 figure, which seems to be the one that's used for the viability? I'm leaving aside the workforce and difficulty employing people, etc. In my questions. The 600 figure, could I ask whether that's takes account of a rural situation as opposed to an urban situation?
You're on mute.
Yes, I'll try and pick this up. So referring to, there's a NHS England produced a commissioning guidance and how to decide on commissioning stroke services, and in section 9.2 of that they had a factors considered for urban areas and also one for rural areas. And what they said for the rural areas that there needs to be a balance between volumes, travel times, and financial stability, viability. They said that standards that must not be compromised are specialist assessments on admission and daily thereafter during the hyperacute phase, and a stroke unit that's staffed and equipped against the best practice specification. So, and also having 24 access to scanning. What they said in the factors about rural areas, that you may have to accept that there may be slightly increased travel times to ensure that someone gets to a unit that has sufficient staffing for those 24 hours and daily assessments. So there is some balance to be had. There are trade-offs with everything. I don't think that there's no good evidence to show that outcomes in Yeovil are better, or Musgrove are worse than in Yeovil. In the most recent stroke Central National Audit Programme, Musgrove Park scored overall a B and Yeovil was a C. I don't think what we're arguing about is what the service is now. It's the concern about what the service will be. And if we do not make a change, there will not be a consultant, a staff to staff a hyperacute stroke unit in Yeovil. And I've actually had the medical director from Yeovil in the last year contact me to say, we don't have a consultant for the next week. And what can we do about that? We've managed to, on a short-term basis, find short-term locums to cover the service, but that's not a sustainable way of trying to run a service and to plan for the future. Probably the worst thing we could do for our patients is to not have a plan for the future sustainability of the stroke service throughout, and for a critical service failure in Yeovil, which could happen if we know that there is a very good stroke consultant in Yeovil currently, whom I greatly respect, but if and when he retires, we do not have a good succession plan for a sustainable, safe service after that.
Robert, I'm not allowed to admonish you because you're not a member of this committee. If you were a member of this committee, I would address you more sternly. But I just point out that the consultant from Yeovil did do holiday cover and has helped at Taunton. So this is a two-way street, and you just suggested that the opposite of that. So can you please just be careful with your comments? I have to be nice to you. This lot I can be really rude to, but you, I just ask you give a balance to you as best you can.
That is the truth. A few years ago, we did try to run a rota for providing 7-day TIA services across, and he did come and work for a few years in Musgrove at weekends. He stopped that a few years ago. That doesn't change the fact about what could happen in Yeovil going forward.
John Bailey.
I'd like to come back on that one, but I have another question as well. I had two. So to come back on that one really is that if you look at the rural situation, and you mentioned that you have to factor in lots of other factors, there isn't a factor in there for the ongoing social care and integrating public health with the medical side. And I just wonder how we would factor that in to make sure that, in fact, what we're not doing is offloading onto one service what could be looked on an integrated basis, and therefore perhaps seen in a slightly different way. It does relate on to the situation I raised about the numbers, the 600 figure, and the variation, or so the comparison between a rural and an urban situation. I know, living in London as I have done, you could pop around the corner to a number of hospitals and the options are there. We're in a different situation here, and I think we need to take account of that. So that's one point. The second one is taking account of the impact of social care as well. And I can't see in the report where that's being done, although we are supposed to be working as an integrated board. And I'll just stop there because that's not a question. But the second question is, so far, and I'm going to applaud this, although I'm fully with Steve Ashton on the points he's made, is that you've actually taken account so far of the consultation and narrowed it down to option A. I just wonder whether there was an opportunity there to say, well, actually, there may be another option B. We rejected option B already, which has come out of the consultation. So as opposed to just saying, well, now this is it, like it or lump it, my words, not yours. then perhaps we've got another option that's come out of there. And Dorset's out of the way, but how can we then factor the service in? We're still on the south of the county. You know, where do we go north of here? So there's still a long way to go. But I just wondered whether there was as a result of the consultation, another option B to replace the previous one, which has come out of the consultation. I'm not sure whether Julie, you'd answer that or someone else, but thank you.
In the consultation, there were a couple of suggestions around alternatives, options that we could think about. One of those was about stroke ambulances, and there was another one around primary care centres having the ability to take patients to assess them prior to them going to the hyperacute unit. Both of those, I mean, I don't know if Rob wants to comment on the stroke ambulances. We have considered both of these about whether they are viable, but neither of them I don't think are at the moment. There's not enough evidence really to say that they are a viable option to alternative for option B. But so no, we didn't get a viable option as far as the consultation was concerned.
Just to about stroke ambulances, we did meet with the PPG chairs for South East Somerset, and one of the discussions was around the use of mobile stroke units, they're called, which is where you have an ambulance which has a CT scanner within. They're usually staffed with either a consultant neurologist or a consultant radiologist or an anaesthetist as well, and so they are quite expensive things to run. There was they're using some urban areas around the world, having first come out in Germany. There was a trial of the use of these mobile stroke units or ambulances with scanners in the southeast of England, and it wasn't shown to be cost effective. And so the most recent national stroke guidelines published earlier this year also addressed based on the issue of mobile stroke units. And they said there's not good enough evidence for their use at the moment.
Can I come back again, Chair? Thank you very much for that. And I can totally appreciate that a unit in an ambulance is just going to be in one place anyway, and it's quite expensive to do that. It's better to have that at the hospital. So we are focusing here on the access situation, aren't we? Which is how people can get to the services within the time that's going to improve their viability and also the cost, reduce the cost to ongoing support. So I'm going to ask another question, which is there then not a possibility of finding ways of working to improve the ambulance support times, which will, and I think probably 2 hours, 1 hour, 25 minutes is a bit unreasonable to get to Taunton, so that actually those times can be cut down on option A.
I think what I'd say is access is important, but it's not the only driver of good outcomes of patients. It's what happens when the patient arrives at a hospital with their stroke, and that's equally important because there are newer treatments available, such as thrombectomy. You talked about this, one of your colleagues spoke about the time window. It's currently 4.5 hours from onset rather than 3.5 hours, but actually there are some people who can arrive up to 24 hours after the onset of their stroke who, when properly assessed, could benefit from treatments such as thrombectomy, but also people presenting after 4 hours or who may wake up with their stroke where the time of onset is not known, who with additional more sophisticated imaging such as something called CT perfusion, we may be able to administer thrombolysis. But this is increasingly technically more complex, and thus is usually better delivered, and the decisions made by stroke specialists. And that's where we have, unfortunately, one of the greatest shortages to be able to do that across 2 fully staffed units across the county. To address the issue about ambulance journey times, I know there's a national drive to try and improve these, and the problem doesn't really usually sit just with insufficient ambulances. It's about ambulances being stuck outside emergency departments, and it's related to the whole flow across the system. And I know that the ICB is working to address that, and that they are nationally as well. So I don't think any of these changes will help to address the ambulance journey times, but I know there's going to be a national imperative to do that. Currently, stroke sits in category 2 in terms of response times, but I understand nationally they are looking to actually recategorize category 2 so that stroke goes into a sort of 2A category. So even within category 2, they may be prioritized, which could help with ambulance response times in the future.
I just maybe build on that, if that's okay, Chair. So yes, we've been working with SWAST as we do for all cases around how do we improve response times, particularly around category 2, where additional investment has gone in. The response times recently have improved, but we appreciate there's a sensitivity around for this consultation piece. So that's kind of, and as Rob says, it's something about improving the handover arrangements within acutes. It's also about opening up options for the ambulances when they get to the scene, about being able to speak to the clinical team before they convey in a more general basis. So there's a body of work around that, trying to improve ambulance availability. Just a couple of other points that were raised. So in terms of, I think it's a very valid point around social care. So there's evidence there around if you get the acute phase of the stroke correct, then that does have benefits to the wider recovery program. So they'll be reflected in the full business case. We haven't brought the full business case today. I appreciate there's a lot of questions around what will be in the full business case. So I'm just trying to kind of provide a bit of an update on that. So that has been, just to acknowledge that is something we're working on. As Rob said, we met with the PPG chairs. I think it was on the 21st of November. So hopefully when we had a long session with them to talk through the concerns that they had, and they seemed, reassured in the areas that we spoke about, which included the stroke ambulance piece that Rob's talked through. And we've picked up in terms of other sort of actions around from the Senate report and around the modelling piece. And we appreciate, we've gone through a process of, naturally kind of taking the wide list of options and then trying to analyse those and get down to a process of having a preferred option. We appreciate that's not sort of, always what others would sign up to in terms of the preferred option, but that's the process we've gone through at this stage, and that's our focus, is to factor in the various comments that come out of the consultation phase and that we're receiving through feedback as we go through other meetings, to try and build that into the analysis of the preferred option, which would be reflected in the DMBC when that is produced in January.
Emily, Councillor Pearlstone.
Thank you. Thank you for giving us all this information. It's pretty dire and concerning for an awful lot of people. And it does feel a little bit like the decision has been made, given the situation with continuing issues with recruitment staff and those sorts of things. As it is a category 2, and you are looking at whether that is appropriate or not for stroke care, can I ask firstly, is category 2 for a stroke the same nationally?
Yes, that's a national directive for stroke or suspected stroke being category 2. I think in Wales they looked at increasing it to category 1, but currently nationally it's category 2.
Thank you. So there is no adjustments made for a category dependent upon whether it is a rural or an urban area. Surely could that be looked at, given that, people are a very long way away and time is of the essence under these circumstances? Thank you.
Any more questions before? Well then, Sue Osborne, sorry. Councillor Sue Osborne.
Thank you, Chairman. A very interesting presentation. Very, provides a great deal of food for thought, and clearly hasn't satisfied the concerns of both this committee and also public speakers. And it's clear when you look at the map on page 86, which is the travelling times, that moving everything up to Yeovil, moving hyper to Musgrove is going to increase travelling time significantly. For the 77,000 people, 15 to 20 is 66. So for over half our population, they are going to see an increase in travel times. And I know that was shown for visitor times. However, it will also apply to the ambulance service as well. And we know that for category 2, the ambulance service response times at the moment are more than double the set targets, which is worrying. What I was going to ask is, in your equality of access, which again I think you've covered on page 105, I don't see any evidence that rurality was taken into account. From Somerset Council perspective, I don't know whether it's yours, rurality in Somerset is considered a protected characteristic. Has that been recognised in your equality impact assessment? Because it's very clear, just looking at the map on page 86, that rurality should be recognised and should be factored in, simply because this is going to impact on 50% of your health population.
Not sure which of you is going to answer the I can't say it question. Oh, that one. Where we all live amongst the trees.
Shall I? We have got an equality impact assessment which does include rurality and also other protected characteristics. But I don't think that rurality is not necessarily a protected characteristics as far as we're concerned. It's mentioned in the equality impact assessment, and that will be part of the decision-making business case as we go forward. So there will be one in place.
My other question is, what discussions are you having with the Ambulance Trust in terms of improving its category 2 response times? Because until stroke is reclassified or category 2 is reclassified, we're stuck with what we've got. What conversations are you having in terms of maybe what additional things or extra recording or data recording on patients could be done whilst the patient is en route? So whilst you're not going for the full stroke ambulance, there could be other things, say, that enhanced trained paramedics could do to increase the success of treatment whilst en route to Musgrave. Because say it is a real concern. And as one other speaker has pointed out, it does look like we are really going to risk a postcode lottery, a 2-tier stroke service in Somerset. And that can't be right for our residents.
So I maybe come in with the general piece on the ambulance service, and then Rob can pick up if this piece of conversations that can help with the en route element of it. So as I already touched on, we're part of a collaboration across the Southwest that commissions SWAST for our ambulance provision, and there's an ongoing piece of work around how we can work with them to improve response times per se across the piece. As I already touched on, that we've got a number of things that we're in discussions with them around how we improve the handover processes at the front door of A&E and ED when they get there. Some of the opportunities I have around being able to deploy technology when they get to the scene of a patient, and being able to have that conversation with the clinical team at the hospital or wherever that needs to be in order to make a more informed assessment about where they would convey them to. And so there's a number of things that, as well as overall capacity within the ambulance service itself, and how they can spread the capacity in a more efficient and effective way, which is part of their ongoing improvement work itself. So there's a number of things that we progress on a kind of ongoing basis around how we improve response times, accepting that it's a key part of what reassures people. With regards, I don't know, Rob, if you've had sort of any further insight with regards to if it's not a stroke ambulance, is there other opportunities to improve the clinical, I guess, conveyance?
So currently what happens when a paramedic crew or ambulance crew pick up a patient who they think has had a stroke, they will look at which is the closest type of acute stroke unit. And certainly at Musgrave Park Hospital, they send a pre-alert to our team. And so that we can send a cascade, which There's a transfer of clinical information about the patients, which enables us to decide what sort of scans they might require. And we book those beforehand, and we know have an ETA, so we know when the patient's going to arrive. We meet them with the porters and with some member of the stroke team and convey them with the paramedics straight to the CT scan. So often it gives the opportunity for the paramedics to cannulate them en route, which helps reduce times later on when they arrive in the hospital. So all patients with suspected stroke are pre-alerted, which enables us to be in a state of readiness when they arrive in the hospital. As David alluded to, there are pilots around the country looking at something called stroke video triage, where paramedics use a body camera to be able to communicate to a stroke consultant who can see the patient and help to decide whether they think it's a stroke or a mimic condition, and whether they should go to a hyperacute stroke unit or go to their local hospital. And that may potentially reduce the unnecessary conveyances to a hyperacute stroke unit when they could go to their local hospital. These are currently being evaluated in pilot sites across the country, and if they're shown to be effective, then it's something we'll certainly explore locally as well. So yeah, all patients are currently pre-alerted, I think, to both Yeovil and Musgrove Park Hospital.
Any more questions? Oh, sorry, Councillor Hilary Bruce.
Thanks, Chair. Just looking at the, going back to, well, firstly, I've got to echo what a lot of people have said already today, that I think it does come across as a bit of a done deal, this decision. We've got one option on the table and that's going to be it. I hope that's not going to be the case, but it does seem that way. What people referred to about the demand, I'm struggling to find in that there's quite a few reports in here, modelling of the population. It talks about ageing population from the 2021 census. What sort of modelling has been done in terms of where we are at the moment with the population and where it will be in 2 years and 5 years and 10 years time? Because this is coming across to me as being quite a short-sighted solution to a critical problem. And I do acknowledge that there's a problem with the workforce and the recruitment and retention, and all those problems need to be dealt with in the short term. But is this a long-term solution? And it doesn't seem to me to be the right long-term solution. So what's the possibility of having another option, which is, this is what we need to do now, but we're looking at something for a longer term solution. What the longer term solution might be, what can we consider? So yeah, just any answer on that? Thank you.
So it isn't a done deal because we've still got a lot of modelling to do. As we said, there's still quite a lot of financial modelling to do. We've been doing geospatial modelling, so looking at travel times for public, those sorts of things. We've still got quite a lot of work to do for the decision-making business case before we actually get to the point of presenting it to the ICB board in January. When we've done the modelling, for the bed modelling particularly, and for other modelling, we've looked at 10 years and we've looked at growth over 10 years. So we aren't looking at the here and now, we're looking at actually how the population grows and then what's required as that growth comes in, and how do we need to increase the number of beds and the number of staff along that 10-year timeline. Does that answer your question? There isn't another option. We have gone with the option A because that is the preferred option. We started out with 9 options. We tried to think of every single option that we could think of, and we went through the process, as we said, of discounting some of those options and shortlisting. Option A is the one that we are working at, and option A is the one for the future. Things change though, and things will have to be reviewed in the future at some stage maybe. But as I said, we've modelled over the 10 years the growth of population.
So we only have the one option. If that business case is presented and the answer actually is no, that's the right option, what happens then?
Yeah, I'll just come in on that one. So we've clearly gone through a process with a set of criteria and a long list of options, as Julie's outlined in the paper and indeed through the conversation. So we were working up then and the deliverability of the preferred option that we've got. If that proves that it's not deliverable, then in conjunction with that, we'll set out the process for what we do after that. In terms of having to revisit what options we do have in a broader sense. But the key thing is, I guess, we were trying to respond to drivers for change, which included kind of the fragility of the workforce model at YDH, and that sort of fragility still exists today. So there's a timeline and an imperative to try and make decisions here in order to be able to produce a viable, high quality service moving forward. So that will be also factored into sort of what happens if the preferred option isn't deliverable itself.
I think there's no other hands. I think it's my turn, and I'm gonna abuse the position of chair and actually and make a lot of points, because as a Yeovil councillor, can I say right at the start, if the proposal was to close the stroke service in Taunton and move it all to Yeovil, the hospital that I trained in, where I live and the people I represent, I would oppose it. And I say this, and I've said it in public before, I oppose it because actually what we need is a national health service, or at least a Somerset health service, that meets the needs of everyone across the county. Just making everything wonderful in Yeovil would not be fair on the people of Taunton. Although it's easier to get to Yeovil from Taunton than the other way round, the reality is that wouldn't be the way forward. So this isn't a kind of NIMBY-ish approach. I believe my views are logical and worthy of consideration. The previous report was over 120 pages long that came to this committee. I read every page, and that's unusual because most councillors read most of it, but they don't read every page. I went through every line. It was a thoroughly interesting report. One of my favourite parts of it was where it showed, I think it was Cumbria, it could have been Northumbria, but somewhere up north. And it was a wonderful graph that showed the length of stay that people had to say post-stroke. And it showed all the work my colleagues in the stroke system have been doing over years, and a steady decline. People were going home quicker. It was brilliant. Then a drawback was it showed when the HCSA thing was introduced. You got the graph, you had it in the document, it showed it made no difference to the trend line at all. The trend line continued the same. And that's because the real work was not what the unit did. It was what my colleagues, my nurses, my physios, that is my assumption, looking at that data, that good work continued. So I was slightly surprised to see it in there. The whole concept of this is something that was developed over 10 years ago. And as Mr. Whiting, I assume, no, you're a surgeon, you're a physician, Robert said earlier, things change, and they have been changing. There's changing knowledge all the time. We're talking about the amount of hours response time. I remember when I trained as a nurse, if someone had had a stroke 2 years previously, you couldn't rehabilitate them. And I believed that until I did rehabilitate someone who'd had a stroke 2 years previously, and they significantly improved. I think we don't know, and I think that the 600 figure, the magic number, is one of the two big problems here, and it's a self-solvable one. There's a reason why it's hard to recruit consultants for Yeovil, because of what Somerset Health Authority, or whatever you did before when you tried to close the stroke unit. Nobody wants to go somewhere if they haven't got security of tenure. If the rumour went round, or better still, came out of this report that actually Musgrove was going to not have a stroke unit, you'd have fragility of workforce, you'd lose staff. This was a deliberate action in the past that's created the problem you face today. But it's a solvable one. All you need to do is say you're actually going to commit to that health, to the Yeovil, and you will get the staff in the same way you've got them at Musgrove. it's a, it's a slightly embarrassing situation where the health service have created a problem that they now need to solve, but solve it you must. I'm pleased that we're down to the one option. The previous option of moving everything to Taunton really worried me. This is a less bad solution, but it's not the best way forward. I believe, and I'd love to see the figures, but I believe in 10 to 15 years' time, there will be the need for this unit in Yeovil. What we need to do is make sure now that any decisions that are taken now do not preclude that, along with responsibility, that if the data shows that if this change came along, there would be personal liability for any damage done to the people in my area. If you make a decision, you have to live with it. And I think there should be some liability within senior people within health, whether it's chief executive or whoever, that if the decision is made and then my death rate goes up in my area, that'd be corporate manslaughter. This is a big decision. And I'd like this committee to be 100% behind supporting a proposal that improves stroke services in Somerset for everyone. This proposal does not do that. There are lots of very good facts within it. However, the geography of Somerset and our rubbish roads means that it's not a good service for everyone. And I actually believe that if we'd gone with the other option, we'd have damaged the services in Musgrave as well because of the increase in the people coming here and the pressure on the beds, not to mention the roads. We have got a second consultant. Apparently he's very, very good. He's looking after Councillor Andy Kendall, who recently had a stroke, a very serious stroke that meant he went to Southmead, and his recovery is fantastic. And thank you to everyone involved in his recovery. But we need 2 permanent posts and we need to recruit them. And the only way we're going to do that is we need to stop the nonsense of saying that Yeovil is not as important as Taunton when it comes to strokes, because that's the message that this consultation has got over. I know that's all comments, it's all opinions, but I can tell you it's the opinions of almost everybody who lives in Yeovil and North Dorset and West Dorset. We were very worried by this, and there's a level of reassurance that we haven't got this really silly plan, but this proposal won't give us the services we need. And I would like that to be the message from this committee. I don't know, we don't normally do motions, but we don't know, we don't. But I don't see why we can't. That's why they don't let me chair meetings often. I would like to propose that we say that this proposal is not sound for the people of Somerset.
With the greatest, sir, with the greatest of respect, we haven't brought a proposal today on what that preferred option looks like. We haven't brought the detail that will be available in the decision-making business case. And I guess the update today was just to advise on the further information that's come in from the public consultation, and also the information that's come in from Dorset County Hospital. Say that by all means, I'm not familiar with the process of the committee, but I just wanted to flag that we're not bringing a full proposal here today. We haven't brought the full information here today for that reason.
Thank you very much. And I am incredibly grateful that you shared all the data that showed the concerns in Dorset County Hospital. And I'm so pleased at the openness of this. It is a wonderful thing. Thanks to Bruce wanted to jump in.
Yeah, I'm not sure whether we can do this in Chair, sorry, not sure whether we can do this in the right time frame, but I would just, normal process would be to put a recommendation to the executive, wouldn't it? And they would write to the ICB to express our concern with the proposal.
I'm happy to be guided. This is a new council, and I would love the executive of this authority to back up this committee and its concerns. There is only one option on the table, and this committee's view is that it's not acceptable. And whilst we support the improvement of Musgrave, we want to protect Yeovil as well at the same time, which is achievable. But I've got Sue Osborne.
Thank you, Chairman. I wonder whether we can do this. I'm going to be very cheeky and ask, please, can we have the final business case coming to scrutiny for us to have a look at before you actually make your final decision in public. Please.
I'm being told that's not feasible. I would, yes, I would welcome it, but I'm not sure it is actually feasible. But I do feel that all the members in the room voted unanimously, should we say, against this option. And I think that message needs to go home. So I'm being steered, and I think it makes sense to me that we should now refer this to our view to the executive, and let where the real power is, and let the executive send a message to health that actually good but not good enough.
Can I propose that we delegate to yourself and Democratic Services to put together that letter to executive with the points?
I think Jenny's far more articulate when it comes to this sort of thing, so I think a combination would be a wise one. Are members happy that we get something to the executive briefly, very quickly?
Proposed, that's all. Proposed by you, Hilary.
Yeah. Is that, can we have a show of hands that people are happy with that? Just keeps everything tidy? Yes, that's unanimous in the room. I think, thank you very much for your attendance. I'm not going to apologise for my robustness. I hope I was polite, if challenging. But we do appreciate the time you've given us. And we do, and that as this committee, that is very, very important. Oh, one final point. You know, the concept of iPads, brilliant idea, but there's been an awful lot of work that shows the importance of touch and how important that is in stroke rehab. It's not, you know, it doesn't work as well, and we saw that with COVID. So touch is incredibly important. Thank you very much for your attendance. I do appreciate it. We appreciate it. Thank you very much indeed. And thank you, ladies and gentlemen, online. I think that concludes our business, doesn't it? We don't have public at the end, no. Thank you very much for sitting here in the cold. Thank you for coming along. And I formally close the meeting at Taunton time 1:12.